And we need to look at substance use disorders in that same way. The couple of the other things that we'll look at today is describing the unique differences in adverse stigma encounters that people experience who are pregnant and parenting. Am I having a?
No,
am I doing this right?
There's a note.
Okay. Oh, okay. Meeting is being recorded.
It's not showing up on here. No.
Oh, I never look at, oh, there it is. Oh, yeah. It's kind of hard to read through that. It's like a veil. Oh, no, that's okay.
No, it's okay.
I just don't know where to find it. It's there, but it won't open.
Okay, I think. Or I'll just show you. 1 second.
Yes.
So I don't know if your mouse will move over to this screen. Oh, I bet it does. You're right. You can just like. Yeah.
Where's it go? There it is.
Yeah, it does.
Okay.
Perfect.
Ooh, tricky.
Only took
so
four.
glad
It
you
only
figured
took 4
that
people to figure out.
Do I know where I am now?
No, probably not. Because I exited out of it. Or I didn't exit out. I just
My favorite
minimized
thing
it.
of every conference is the technical things.
But now- How do I get it back? There we go.
There, okay.
Got it.
Oh, okay,
All sorted now.
all right. So, so we're also going to describe some opportunities that we can change the stigma that we all live with and are exposed to towards pregnant and parenting persons, and to be open about unlearning some of the myths that we carry with us and the misinformation that we get. Recently at an event in North Dakota that's sponsored by our governor and his wife, who is in long-term recovery from alcohol use disorder. It's called Recovery Reinvented, and it's a great big thing. They've been doing it for 7 years, and they invite people to just come and talk about recovery and to be really open about it. But the governor of North Dakota, who's also running for president of the United States at this point, but he's also always been such an advocate for substance use disorder and recovery. But he said, not only were we there to learn that day, but we were there to unlearn. And it just resonated with me to hear it put that way. And I appreciated his efforts to help us to look at, and all the people who were there and all the people who were online listening to that, to take an opportunity to really look at our own stigma and our own biases and how we feel and how we think and how we respond to people with substance use problems and how we're impacted by them. So that was a quote from him, but I put it as an objective because I'd really like us to do that too. So we look sometimes at why do people want to use substances? What is it about them? And drugs of abuse hit the pleasure parts of our brain. And we could spend, a month talking about the brain science, but I just wanted us to remember that those endorphins are released in our brains and in our bodies by those substances in ways that our bodies were never designed to experience. So people who utilize substances of abuse and experience this dopamine release, this is just to give you an idea of why we deal with this issue and why people are so attracted to the substances that they use. So we may have a baseline of about let's just say 100% dopamine in our system when we live and enjoy things in life or whatever. So if when we eat and we have a very pleasurable meal, if I had that sip of that Seattle's Best coffee this morning, my dopamine level probably shot up because as Andrew said, I drank, brown water at the hotel. so mine is probably right up there. And people respond to video games and action like that. If you have sex and experience an orgasm, you're probably up to about 200%. If you inject cocaine or snort cocaine, your dopamine levels go up to about 450% in your brain. If you inject or smoke or use methamphetamine in every way, all of a sudden you're at 1,000%, 1,000. And then, or any amphetamine, but methamphetamine, you're up in the 1,300% category. So you think about that dopamine release and how people feel. And the first time that they use methamphetamine, they'll say, I knew I was addicted from the very first time I used it because I've never felt that way before. Opioids do the same thing. Cannabis does the same thing. All of those substances of abuse and all of the things that we do to bring pleasure and enjoyment in our life respond to that pleasure center in our brain. But what happens with substances of abuse, it hijacks the brain. It tells us, keep doing this, keep doing this, keep doing this. This is what you want. This is what you need. And that's what people are responding to and what they're fighting against when they're trying to seek recovery, is finding ways to feel that kind of pleasure and joy in life again, and enjoy a quality of life that they can embrace and live with without that haunting call to continued drug use that sets us up for dependence and for lapses into additional use. So that is the nature of what they are dealing with. So this is a change in brain chemistry. So people with addiction illness, and we still use that term addiction, but we in our language, we try to talk more about substance use disorder or substance use. But addiction is a diagnosis. It occurs in the human condition, and it's still utilized in medical terminology and in even in you know the governing bodies that set our methods of practice, the American Society of Addiction Medicine. So that word is still utilized, but we talk about later in context, better words to use in the way we talk. But persons with addiction become less motivated by just everyday stimulation. The relationships and the activities, the things that are important to them, family, the love of the people and the things that they do in their life aren't remotely as rewarding and motivating to them as the drugs that they've become accustomed to having that kind of response in their system. So those changes are deeply ingrained, and we can't expect people to change that overnight. And they have a very difficult time sometimes reversing that and coming out of that kind of stimulation into an ordered life or a quality of life that they will embrace. So chronic disease, as we know it, is characterized by signs and symptoms. It's a combination of biological factors and behavioral and environmental things. It results in damage or in change in function to the body system. And if it's untreated, it can lead to loss of function and death. But control is what we need in order to manage chronic illness rather than effect a cure. We can't often effect a cure, but we know how to work to control it. This is the same, it's the true with substance use disorders as well as with other chronic illness. And you think about the people that you've treated for diabetes-related problems or hypertension or asthma, and whether or not they return to clinic in a state of lapse into old behaviors again. And they do. It happens all the time. I have type 2 diabetes, and I can say that I do not stay strictly, I have a donut occasionally. I had a Danish this morning. I mean, if I had to do rigid control of everything that I've been taught, the exercise, all of those things, there are days that I do better than others. And the same is true for substance use disorder. The same is true for people with hypertension. They don't remove the salt from their diet. They don't exercise. They come back in to see you. Their blood pressures are sky high. You have to change their medications, add something, to go through the benefit and the risk again, all of that. The same is true for substance use disorder. And to think about it in the same way we think about other chronic illness helps us to understand what we're dealing with. So what if we treated other diseases like we treat substance use disorder? So on Inauguration Day in 2020, I had a heart attack. And I was at home watching the inauguration, and it just soaking it in. And I had woke up with chest pain that day, and it got worse. I checked my blood pressure. Oh, and I thought, oh, Marvis, you're having a heart attack. I know what the signs and symptoms are. So like every good nurse, I went out and got in my car to drive myself to the hospital, you know. So, and then I realized when I was there, I was sitting in the back seat, and I thought, Marvis, you're not going to get anywhere unless you drive yourself there, because nobody's here with you. So I got in the front seat. I don't even know how I got to the hospital, but I did. And I walked into the emergency room, burst into tears, and said, I think I'm having a heart attack. Well, from that moment, I walked in there. Everything that occurred in the next year, every single thing I did, cardiac rehab, lost 95 pounds, did all the things that they told me to do. I did everything exactly the way they told me to do it. And I affected a completely different lifestyle, truly. But not once did people say to me, gee, Marvis, this is your fault. It's these terrible choices you made about what you eat, that you don't exercise, and and you're under a lot of stress. And nobody denied me treatment because I did this to myself. And I wasn't given a list of cardiologists that said, call a cath lab, you're going to need probably some treatment, or only given an aspirin if I agreed to go to counseling, or got kicked out of the hospital because I experienced more chest pain. This is exactly what people with substance use disorders are faced with each and every time they have an encounter with someone who doesn't understand substance use disorder or how to treat it. And they seek care in emergency departments or in clinic situations, and people who don't understand the process that they're in, or know how to or don't feel confident in discussing it or treating it, are faced with with a hesitancy to even bring it up or to know what to do to talk about it. So if that was the case, we would, we'd be in big, but you look at what chronic disease is, and substance use disorders have exactly the same kinds of of definition. There's compulsive drug seeking, we call. I'd like to change the way you think about that, and to think about when people are seeking more of the substance they're dependent on, they're relief seeking. We had a wonderful presenter that talked with us about changing that word, about people drug seeking. They're relief seeking like everybody else who comes to an emergency department for a broken bone or a heart problem or an asthma. They're seeking relief of their symptoms. That's what people with substance use disorder do. It causes a combination of these behavioral and environmental and biological factors. It causes long-lasting changes in the brain. And if you leave it untreated, it's disabling and it's life-threatening. And we can control it, but we can't offer a cure to people. People used to talk about going away for the cure, but that just isn't the case. But we can offer people ways to do control. Alcohol is still the most commonly used substance in the United States, the most common in all of the United States. But drug overdose is the leading cause of accidental death now in the United States, everywhere. Opioids are what has driven this epidemic, as we well know, and the increase in fentanyl and the flood of fentanyl in our country has caused a significant increase. About 186 people every single day in the United States die of a drug overdose, a drug opioid overdose, 186. Stimulant use remains a very significant problem in our region, and it never really went away. And the methamphetamine that we have available now is made in laboratories and floods the regions. There's very few little mom and pop operations still going. We still hear about them once in a while, but primarily the methamphetamine is manufactured much more potent, and the expectation and use of it, and it's so cheap to buy. So is fentanyl, very cheap to buy. So it's not the cost that keeps people away from using. And there's a significant increase in stimulant and combination overdose death with opioids. The fentanyl has such a strong impact that people use it in combination or use stimulants to offset some of the overwhelming kind of effects from the fentanyl. So we're seeing a significant increase in that, just to give you an idea of what we're facing. So about 10 to 15% of the people that you are seeing, maybe more than that, but that's an estimate of our patients, of the patients that we see, have a substance use disorder. Whether you address it or not, whether you know about it or not, they're in your office, they're in your practice, they're in the things that you do on a day in and day out basis. So screening for substance use disorder should be routine for everybody at each visit, or at least on the yearly visits that we do these screening. We're going to talk about the tools that are available. Some of them are very simple to use. And all it does is open the conversation and give people an opportunity to talk about their substance use in a way that will bring up the topic in a safe spot. And they'll look at you and look in your eyes and look in your face and not see judgment, not see an unease in discussing it, but just to look at it in the same way you look as you ask about the care of their feet, or their, what's your stress level, or all those kinds of, but you ask the questions about drug and alcohol use, it normalizes the conversation. But people are dying, and they're at a rate that we've never seen in our country before. And there is evidence-based, federally approved, highly effective treatments available for people that are not being utilized the way they could be. Harm reduction, harm reduction, harm reduction. I just say this too, that this is such an important aspect of care. No one discipline or one agency or one person can solve this issue. It's taking all of us to do this. And you may already know about some of the medications for the treatment of substance use disorders, but there's great evidence in clinical practice, and it's getting easier and easier for people to feel confident in prescribing them. There's great education and training available for people to feel confident about working with this issue. So it's not the anonymous kind of illness that it used to be. So some people are more predisposed, of course, to substance use disorders than others. And that has to do with history and physical makeup. But regardless of who uses substances, it changes your brain activity. The human body is really built to be in balance. And it takes a while for us to get back to a homeostasis homeo, I always forget the E in there, but it's homeo. And it takes a period of time for those people who have had significant usage to reach that balance. We have to give them time to do that, just like we do with any other chronic illness. It took me a whole year to effect the change that I wanted to from that day in 2020, but I had the support of a remarkable group of people to do that. Not just my people at the Sanford organization, but my family, my coworkers, everybody. And that's what we need for our people too. This is an addiction tree. This is a wonderful visual about addiction and how many types of addiction or dependence there are. Certainly substances is what we're talking about today, but there are people struggle with all kinds of substances. Tobacco is often the first thing that substance that they ingest, but alcohol, opioids, cocaine, and many other substances. But see, people also develop a dependent and addictive kind of approach to gambling, to exercise, to sex and pornography, to work sometimes, to video games, to our phones and our technical stuff, to food too, to caffeine, to sugar, to carbohydrates. We all have some types of addiction, but we look at that addiction tree and it levels the understanding of substance use disorders too. Substances, all of those things we can get out of balance with, all of those things. But the addiction tree looks at how we used to develop, and how still sometimes in treatment, we expect people to come out of their current situations and they go to treatment, they get all this wonderful pruning and grooming and education and training, and then they leave treatment, they go back to the same sites that they came from. And so the root system is the same. And many times the things that have caused the change in their drug and alcohol use can be related to trauma, to neglect, to the kind of verbal and emotional abuses that they've been involved in, or sexual abuse. And all of those feelings that surround that are a part of that root system. So one of the things that we've really focused on too in the last years is trauma-informed care and understanding where people come from. And that when they come to us for help, we don't say, "What's the matter with you?" We say, "What happened to you? What happened to you?" And hear their story and hear from where they came and what is going on in their lives. We have absolutely no clue, for the most part, of what people experience with substance use problems, what they do to survive. And truly, when you put yourself in a room with someone with a substance use disorder and you look at them, you should think, this is a survivor. This is someone who has a lifestyle I can't imagine, that maybe you can. Maybe you're a person in recovery, and that you're approaching people with an understanding of this illness, and you can help them affect a change. But that trauma-informed care and just having an awareness of where people are is really important. Stigma is the definition is a mark of disgrace or infamy. It's a stain or a reproach as on someone's reputation. So that's what the word means. It remains the biggest barrier that there is to addiction treatment faced by patients or clients that are seeking treatment. It is the number one thing that keeps them away from reaching this. So a lot of words go along with stigma, a lot of real negative connotations and feelings, despair, disgrace, shame, humiliation, embarrassment, discrediting them, discrimination against them. They're scorned by society. All of that negative connotation comes with what stigma is about. And it isn't just substance use disorders that people experience this with. It's mental health issues. It's all kinds of issues that where people do not follow a standard that we set in our own minds and our own beliefs. And they're beyond that, below that, or above that, or whatever it might be, but that's what they live with. So where does stigma come from? Everywhere, but family members and friends probably are have the greatest amount of it, that they deal with it, and that impacts a person with substance use disorder. Families get worn out. They get really worn out. And friends of people who have substance use problems see these same behaviors over and over and over again. And the stigma that's attached to that has to do with the fact that there's no recovery, no effort added, or here we go again, or what happened, or it is so stigma comes from that source, but also is poured on that source of people. Healthcare providers have a significant amount of stigma in their practices too, and we're going to talk about that today. Coworkers, employers, people who work with people who are not living up to the job that they're supposed to do. They're picking up after them. They're covering up for them. They're doing all kinds of things, but it impacts their bottom line and the things that they want to accomplish. Counselors in recovery organizations sometimes carry a stigma, who believe in only abstinence-based programs, and that's their focus, and have a hard time looking beyond that. And I was raised in 12-step belief in abstinence-based programs. It took me a long time to embrace and what it took was the number of people that we weren't helping. We had a percentage of people that found recovery, remained abstinent the rest of their lives. Those were the miracles. But what happened to the other 60 or 70% of the people that we were serving who lapsed into use? And we always thought, well, it's their fault. They're not doing it the way we told them. If they only do it this way, this is what would happen. But, we all had to come around to a understanding with the brain science as we learned more and more about it. And we started looking at the evidence based in the actual science of substance use disorders, that we came around to understanding. And a different approach was going to be necessary for a lot of different people, that we needed to look at the individual and what their needs were and meet them where they're at, rather than looking at this as a group illness or even an anonymous one. And treatment organizations, and sometimes, you know, even our own policies and procedures produce stigma. We have very specific confidentiality protection for people who have substance use disorders that aligns them in a different way than anybody else that we're treating for any other chronic illness. And why we made it that way, and why it is that way, and why it's anonymous, and why it's protected and that sort of thing, was to allow people to enter treatment services with and leave that stigma behind. But it doesn't work that way. It just doesn't work that way. It's still carried into it. And criminal justice organizations have a significant impact on the stigma with this too. We try to address the drug problems in our country with criminalizing it. And so our prisons and jails are full of people with substance use problems who do not get the rehabilitation that they need there in order to come back out and transcend into the communities again and learn to live a life that's different than what brought them to that site in the first place. So that doesn't work either. Criminal justice approach to drug enforcement has not worked for us in our country either. Many other countries, they have very different approaches that are much more impactful and humane. So there's public stigma or stereotyping that we hear all the time or experience in our life through you know, the social media, through the conversations we have with others, for the way we were raised, the way our family thinks, how we are inundated all the time with the way we should think and the way we should believe. Enacted stigma is discrimination that we see and that we experience too with people of color, with other cultures, but that's enacted stigma. Structural stigma refers to institutions that discriminate against certain people. We won't accept certain people into our organization, to our structure, to our work site, to whatever it might be, but that's a structural kind of stigma. Self-stigma is the blame and guilt and remorse and misery that people bring on themselves because they feel at fault for their own substance use problems and addiction. And affiliation stigma is being affiliated with, you know, people. These are the persons who are affiliated with people who live with this kind of stigma. So it's their families, it's their caregivers, it's their others that live with the shame of having someone in their family who has a substance use problem and trying to keep that secret and keep that covered up, or have a family member who dies of an overdose and is horrified at other people finding out. And how do we handle a funeral? How do we even talk about this? And you see more and more now that people are sharing the experiences that they have and living in a life that is out loud with recovery, that they share their recovery and they share their lapses back into use. And families who experience addiction address it in that way. And they talk about their people who have had substance use problems or have died of overdose and share that in very brave kind of obituary kinds of approaches to that. We're more and more seeing that. But the effect stigma has is that people are less willing to go to care. They're afraid about how they're going to be treated. They're not accessing the resources they should. And it really has a negative impact then on physical and mental health all around. I just want to make sure. Okay. Some factors that influence stigma are blame for the choices that people make, the stereotypes that we have, the knowledge or the lack thereof, or the experience or lack thereof that we have working with substance use problems. The confidentiality, the 42 CFR, it's the confidentiality law that protects people and their information about substance use problems. I mentioned that earlier, the media, and then other things that affected our race, of course, and ethnicity and cultural differences. All of those things can really influence stigma. It can influence them in a positive and in a negative way, but these are kind of the negative impacts that we see. So with women with substance use disorder and stigma, they have another whole set of issues and stigma to face. So women are now the fastest growing population of people who use substances in the United States. Youth is down, but women are using it at a much higher rate. Sex and gender really make an impact on addiction. How people perceive themselves, the biological factors of the way our bodies work, even menstrual cycles can play a role sometimes in the course of the use of substances of abuse. Women who are viewed as mothers and caregivers, gatekeepers, the center of a family unit, and that's the culture we live in. And women with substance use disorders have been considered selfish, or they have a moral failure, or they're believed to be a result of being intentionally harmful to their families, their child, or placing this huge burden on society. And this strongly drives that self-stigma I was talking about. People internalize, women internalize that kind of narrative, that belief that they get in all the areas where they talk about their substance use and feel this overwhelming sense of stigma. And that blame just grows, and that shame and that guilt, to the point they're having a very difficult time when struggling with that. So they really struggle then between disclosing what's going on with them and keeping it a secret. There's sometimes people begin to isolate themselves or just spend their time with people who are like-minded and will accept their use. So it's more and more common to see this prolonged isolation to be more common among stay-at-home mothers, rather than those who are, out in the community or involved in activities, or they bring about this isolation in order to protect themselves. And we see a lot of greater impairments for women in their social functioning, in their relationships with their friends, with their family, and with employment as well. So women of color are disproportionately noted to deal with stigma as well. So if you add the culture and ethnicity on top of that, as well as substance use disorder, you can see the problems they face. Women have a faster onset with their substance use disorders, from the onset of their use to the point where they reach dependence on those substances, and for their first admission to treatment. Especially that's noted with women who use opioids, who use cannabis, and who use alcohol. They just have this telescoping effect. They don't have a long progression. They have a much shorter progression of their symptoms as they go from mild, moderate to severe kinds of symptomology with their substance use. Women absorb and metabolize and eliminate alcohol and drugs differently than men do, just because of the makeup of our human bodies. And they tend to enter treatment with more severe clinical profiles than men do, because they have medical issues, they have behavioral issues, of course, that this is a behavioral disease, and psychological problems, and then social concerns. So they have this rapid onset and overwhelming baggage that they bring with them to seeking treatment. So the differences in our stress response to and our reactions, it makes us more susceptible to cravings and to return to use. So many times women will resort back to use to deal with the anxiety that they have in their early recovery, to the low self-esteem issues they have, and especially now with the understanding of depression that women deal with in early recovery as well. Very concerted efforts now to screen and address women for depression in the postpartum period, but also during the perinatal period as well, and even in preconception to assess women for a level of depression and isolation. And women are more likely to engage in kind of binge-like using of patterns of drug intake, where they will plan it or binge for multiple days in a row and then go periods of time of not using and then binge again. So they have more of that binge pattern than that daily constant use pattern. And women are more sensitive to pain. I always hear it the opposite way and believed it to be that. But in the studies, they're more likely to experience chronic pain as well and be able to describe it differently. And and expect treatment with opioids at higher doses more rapidly and longer term use than men do. So that may have changed in the last decade of use with opioids, where men were prescribed in much the same ways and overprescribed in much the same ways as women were. Women also have this increased rate of co-occurring disorders and may not be identified and treated for the mental health concerns as well as the physical health concerns in their episodes. So providers tend to miss sometimes the signs of addiction and mental health problems, especially in older women and younger females. The expectation for women of childbearing age is a little more because we see them more often in services, but it is so sometimes those younger groups and the older groups are overlooked in substance use issues. So the bottom line of that is we need to screen for all substances as well as mental health issues and treat co-occurring disorders as well, co-occurring medical and emotional and mental health issues as well. The other thing about women and stigma and women with substance use disorder is that 1 in 3 women have experienced intimate partner violence, and that escalates when women are pregnant, and during that perinatal period that they report intimate partner violence increases, and they're then at increased risk to use alcohol, nicotine, and other drugs. And there's more economic barriers to treatment, that people are less income, they have pay gaps, they live in poverty prior to substance use disorder, and that just perpetuates the problem and the issues. So with motherhood too, pregnant women with substance use disorders are stigmatized and prosecuted at times for their substance use, and this leads to financial, emotional, and legal consequences for this population too. Many of them, when you look at the statistics of women in prison, have a very high, sometimes between 85 and 95% substance use disorder of the women who are in treatment or who are in incarcerated populations. And after pregnancy, women with substance use disorders get continued perceived stigma from healthcare providers and the general public and their loved ones and themselves too, and the addiction community who has, we have special considerations in addiction treatment programs for pregnant women. They go to the top of the list if there's a waiting list, and women are given special considerations, but not always are they given appropriate treatment or treatment designed specifically for women's issues. But they're given, we identify that they should get care quickly, but it's not always the most appropriate. But about 70% of women who go into treatment services have children and are the primary responsibility for their children. So they're worried about where are they going to go? How are they going to, who's going to take care of their children if they have to go to a residential treatment? And so many people don't seek treatment because they also fear the legal action that might come against them and social servants' involvement if they disclose that they have a substance use issue, that the mandated reports go in. They're overwhelmed by the fear that they have of losing their children to the legal system. So part of our work is recognizing in the survivors that we work with and those people who are in our care, is that these are some of the feelings that they have and some of the learned behaviors that they have in order to cope with the kind of stigma and lifestyle they live with. They're profoundly hurt. And if you, by all of this, and they carry that shame and guilt with them, but they also feel betrayed sometimes by the people that love them the most or profess to. Sometimes it's their partner, sometimes it's their family who loses faith in them and doesn't want anything to do with them, but they feel betrayal. They develop then a high sense of mistrust of people. And they look at you and think, now, why would you care about me? What benefit are you getting from this? I mean, it just is this negativity that they expect from the people that they seek services from, if they even do. they're highly frustrated, easily react to things, and have a quick reaction to something you might be trying to explain to them and that sort of thing, and have to, reiterate it or re-explain it, or, wait for a time when it's more appropriate to discuss it, or whatever it might be. But they're very quick to react and have a tendency to blame other people for their problems. That is part of survival, is to not look at your own responsibility in what's going on around you, but you can blame others for what's happening. And they may feel entitled to your the exclusivity of their care, and they have a very high expectation sometimes about what you can do for them and what you can do to affect a change for them, and they want it right now. I mean, so sometimes they're very difficult to deal with in challenging that kind of expectation. And sometimes in their they use very deceptive maneuvers to avoid answering a question honestly. And they're very careful about what they tell you and what they're ready to disclose. They test you with certain information sometimes, and then are deceptive when you try to clarify that with them. Sometimes people use very graphic details in telling their stories that really impact us. And I've done a lot of training and work with people on compassion fatigue, and the impact that that has on us as professionals, and what that does sometimes to our own psyche and how those things live in our memories and of those people, and if impact the way that we deal with them, because we have a profound sadness or change in the way that we respond to the stories we hear and what we see, what we experience as professionals. So sometimes people do that, share those graphic details without having any idea of the impact it's having on you, or on the caregiver, or on the person that they are sharing this with. So we ask for the information. Sometimes we get way more than we anticipated, but it gives us an opportunity to work with that person, and then work with our team of people too, to help us deal with those kinds of issues and learn how to take good care of ourselves. But people are generally very hesitant to tell the truth, because they sometimes don't recognize the truth, but sometimes they know the truth and are afraid to disclose it, live with fear. And that's primarily the thing that they're feeling. The best practices that we have right now is the new changes that we have in prescribing prescription drugs. What led us to this crisis is the prescription drug epidemic. We've probably all heard about this, know a lot about it, have seen the movies, have seen the disclosures. But the CDC did come up with guidelines to help people who are prescribing, who have prescribing ability for narcotic medications, to change the way that they do that. Every state in the United States now has a PDMP, or that pharmacy disclosure information. So if people are seeking medications from multiple sources, or early refills, or that sort of thing, we have an ability to look at their history and be able to identify it, and to work with that person who is seeking that kind of relief from multiple sources. We also have more access to naloxone than we ever have had in our country before to prevent overdose deaths. We're doing an enormous amount of training. Naloxone, everybody should have it. Everybody should carry it. Everybody should have it in their cars or in their homes, like in a first aid kit. We do a lot of training about that, and the resources are now changing, because now it's available over the counter without a prescription. But there has been a move that anybody who is prescribed an opioid for any reason also is given the Narcan to take home with them too, and trained on overdose prevention and overdose treatment, so that it can be your grandma that takes an overdose of opioids, and she's prescribed it for a broken hip and doesn't remember if she took it or not, takes more. So you can, experience an overdose and an unintentional overdose, and the Narcan can be there to save that person and bring the emergency medical team in to assist, but in the meantime, save a life. So everybody should learn how to utilize it and save a life. Medications for addiction treatment have been around for a long time. We use a lot of different kinds of medication to treat alcohol and alcohol withdrawal. There's the medications, the FDA approved medications for the treatment of opioid disorder. So those are our best practices right now to address this. Harm reduction programs sometimes give naloxone without any question, without anything but a person asking for it. The pharmacies now will provide it over the counter and increase its availability even more. We had a young nurse that talked about going from door to door on the reservation that she lives on and teaching all the grandmas on the reservation about Narcan and giving them a dose of Narcan. The prevalence of fentanyl on the reservation is so great. So, you know, that's what she did. They couldn't come to the community meetings or the community trainings. So she went out in a home visited and brought them all Narcan. So, I mean, that's the kind of effort it takes and the response that we're going to need. In our rural areas, and we have a 30 to 45 to an hour wait to have an ambulance address a call for 911 help. We have a lot of work to do in our regions. We have a lot of rural areas. MOUD outcomes, if we use medications for the treatment of opioid use disorder, it reduces illicit drug use because people are seeking medical care for a medical problem. And they are receiving medications to treat their opioid use disorder in a way that is supportive and monitored, and they have a return to function. It's amazing to watch this and how it occurs in appropriate use of these medications. It reduces overdose deaths. It decreases the transmission of infectious diseases. People are not using injectable drugs or not, have the exposure to infectious diseases they had earlier. And it also allows us to screen them and test them for those infectious diseases, the hepatitis and HIV, to treat those co-occurring disorders at the same time we're treating their opioid use disorder. It certainly decreases criminal activity. People are no longer having to steal, to seek substances on, in illicit activity. And it increases their social functioning and retention and treatment. People feel much more settled right away when they are stable on these medications and can engage in all kinds of treatment process then that will help renew their quality of life. And it improves fetal outcomes. And it is, so mothers who have an opioid use disorder, pregnant and perinatal mothers and postpartum, the evidence is clear that use of those medications during pregnancy is by far the most evidence-based practice that we have, and the impact has been very positive. So these are the medicines that we use for alcohol use disorder. There's an injectable use of naltrexone that is given in a monthly injection that's used for both opioids and alcohol use disorder. And naltrexone is given intramuscularly about every 4 weeks. With alcohol use disorder, it reduces the craving for alcohol. And in about 50% of the people who are using it, it's not effective for everyone, but for many people, it reduces the craving. And if they do drink alcohol, it reduces the amount of alcohol that they get no kick out of it anymore. It doesn't have the same effect. They don't drink as much. So it's a harm reduction effort as well. Naltrexone for the use of opioid use disorder is also given in a monthly injection. And what it does is block the opioid receptors. So if somebody tries to use another narcotic, they don't get any impact from it as well, because the naloxone is tied to all of those opioid receptors in the brain and in the body, and the narcotic can't get on those sites. So for opioid use disorder, methadone has been around for many decades now. It's very effective. And what we're finding with fentanyl, because of the power of this drug, that methadone is more often now needed and prescribed for the treatment of people who become physically dependent on the fentanyl, because it is a full agonist. I'll show you that just a second. And it fills those receptors in the brain much better. People stabilize much faster. And buprenorphine or Suboxone is a medication that is a partial agonist. For the first decade that we utilized it for the treatment of opioid use disorder, anybody who wanted to prescribe it had to go through a DEA training and they had to get a special license to utilize it. That's been removed now. Any prescriber who has can prescribe narcotics can also prescribe buprenorphine without that training. There are trainings available for people who want to learn more about the use of it, but they are on demand or through an organization that we're partnered with, PCSS, a professional something help you with everything. I can never remember the acronyms. So, but they do wonderful training sessions about opioid use disorder and the use of these medications. So buprenorphine can be just buprenorphine or in combination with naloxone too. So it is often utilized in combination too. It gives people better coverage with the naloxone on those. The buprenorphine is utilized much where it covers the receptors, but the naloxone is in the system. So if somebody tried to use a narcotic, it would put them right away into withdrawal. It has its impact on that. And then for nicotine dependence, we've used Chantix and bupropion, or Wellbutrin or Zyban, and nicotine replacement therapy, which has been around a long time to help people with dealing with their nicotine dependence. So those are all federally approved medications. But this is how the receptor site, methadone being the full agonist, fills the receptor site completely. A partial agonist has that it fills the receptor site, but people do not have that euphoric kind of high. With methadone, people do have that euphoria. It's a full agonist, like morphine is, like heroin is, but it's given in opioid treatment programs where it's carefully monitored. People come for daily dosing of methadone. That's how it's been distributed for decades. People come to the opioid treatment program. They get a daily dose. After, it's a number of months or a year even, they can have a take-home dose or take-home doses. But for the most part, it is counseling and daily kind of contact. Buprenorphine can be prescribed for, in a clinic practice, and people can induct the buprenorphine at home. They can continue to take it. They come in for regular visits with their provider, but this is a partial agonist. People feel stable physically. The withdrawal symptoms are gone. The craving is managed, and they are able to think clearly. They don't get high from this medication, and they are it just stabilizes them. It's an amazing response to that medication. We didn't have this for many years in the early years that I worked in. And probably our highest rate of relapse was people with addiction to opioids, primarily heroin in those early years, that their rate of relapse and premature death really was very, very high. So this to me was a miracle when we got an understanding of this medication, and I saw it, how it worked for people. It was amazing. And then naltrexone I've already described to you. So we hear non-stigmatized conditions that we hear and that we deal with every day are, things like hard to treat cancers. There's no perceived fault with people about the development of cancer, and there's low perceived control that people have over cancer, that when you are diagnosed, this perception exists, and it's not a stigmatized condition. People feel, they bring you cakes, they worry about you, they pray for you, they support your family, they do all of that, and everybody tries to help in situations like that. With substance use disorder, this is a highly perceived fault of the person somehow, that it's their fault that they have this problem. It's a choice that they made, yet nobody chooses to develop a substance use disorder. But it's a highly perceived truth that you are in control of this, not any more than you are in control of developing diabetes or heart disease, except by changes in lifestyle and doing that sort of thing. And we do a lot of work in prevention with substance use disorders too, to help people to have better education about how this begins and how people are at greater risk of developing problems and genetic predisposition and exposure to substance uses, to try to prevent people from having to experience a life that's filled with substance use problems. So the root of the medications for opiate use disorder, that related stigma, is that people still look at opioid use disorders or all substance use as a moral failing of some kind. There's just something wrong with that person. And it primarily, people tend to look at the medicines that we use for treatment of substance use disorders as just substituting one drug for another. Well, you know, that's certainly the case with people who are insulin dependent, that we're substituting a substance they can no longer manufacture themselves or no insufficient amounts. And we have the benefit of the wonderful substances that we have, medications that we have to treat other chronic illness. That's what this is about. That's what these medications are about. It's specific for that treatment. And secondary stigma is the lack of knowledge that we have about these medicines and the effectiveness that they have, the remarkable effectiveness that we have. As we listen to Lucy now, we are going to hear from her about her experience. This is a person with lived experience with an opioid use disorder, and I'm real anxious for you to hear from her. She is a remarkable young woman, and I'll happily to transfer this to her. She's online waiting. Okay, so.
Get it all sorted.
Finish the rest of this.
Yeah, so she is online. Yep.
Yep.
Hey, Lucy,
Hey, Lucy, could you
the sound check. Real
do a
quick.
sound check? Yeah, we're just trying to figure out audio for your presentation.
Can you hear me?
Nothing.
Cannot hear you.
You can hear me?
No.
It's not even coming through.
I wonder what she was. I think it's on our end. I don't think it's on you. Yeah, she is on.
Could we change the speaker to
Here.
Now try it.
Can you hear me now?
Yay! Yes.
Oh, good. All right.
Made it that.
Yes.
Can you guys see me okay? The sun's kind of bright.
it lights you beautifully.
Okay, good.
Look radiant.
Oh, great. I tried to shut it, but then it's just like really dark, you know? So
Cool. So yeah, we'll just start in like another 2-3 minutes. We're just grabbing some more coffee and stuff. So thank you.
yep.
We'll get started. Our next speaker is Lucy Bird. Thank you for joining us, Lucy. Lucy is originally from Dickinson and has made the area her home with her husband and 2 children. She's a recovering addict who has worked in the recovery sector for 6 years. She has a passion for helping people through their addiction and recovery and educating others on the stigma that comes with it. So go ahead, Lucy, if you have any slides or anything, you can share your screen. The floor is yours for the next 45 minutes or so.
Can you guys see me okay?
Yes.
Okay. I'm not doing any slides today. I'm just going to share my story with you guys. I guess the introduction, thank you for that. As you said, my name is Lucy Bird. I am a recovering addict. I have been clean since January 3rd of 2011. I am married to a wonderful husband. I have 2 beautiful little boys, ages 9 and 7. I am currently the director of the Men and Women Sober Living Home here in Dickinson. And I also work as a care coordinator through the state. All things considered, I have a wonderful life today. I really do. I'm so blessed. But it has not always been this way. And so to share how I got here, I'm going to share where I came from. I can remember as early as my memories go, that I just never felt okay, right? I never felt okay in my own skin. I didn't feel like I fit in with my friends, with my families. I just always had this anxiety and discontent and I just really at the time obviously did not know why, but I just was not okay in my own skin as little as I can remember. I've heard a lot of people's stories over the years within the program, and so many people talk about like their first drug or their first, drink of alcohol. Mine was my first time that I smoked a cigarette. I stole my parents' cigarettes when me and my cousin, when we were 9 years old, and went across the road to the dirt ramps. And we both lit up that cigarette, and we both coughed, and I got dizzy and I got sick, and so did he. And he was like, nope, this is disgusting. But that is not what happened with me. I felt all the same things, but it was like, whoa, like that felt good, right? Like this feels good. And I didn't even really know why, but I knew that it felt good. And I was like, okay, that's something that I need to do. Like that felt great. And so of course I started doing that obviously more often and stealing cigarettes, and which led to, taking beer and stealing alcohol from my parents, and getting some really nasty ditchweed from an older friend and trying that all while on my bike, right on the dirt ramps, and just running after that feeling that I felt, right? Like running after that feeling of just feeling okay. And I did that for a few years. Just whatever I could find, really. I was really young. Their availability wasn't a lot, but I started to get involved with the right people. Well, the wrong people, but the right people for me at the time. Older friends, my friends' older brothers and sisters. And drugs became more available to me. The marijuana, tried opiates for the first time, a little hydro pill, things like that. But the first time that I can remember really having an aha moment was when I tried cocaine, and that was at 12. I took my first line of cocaine, and it was almost over from there. That was game changing for me. That feeling, for whatever reason, it made that restless and discontentness in me settle down, even though you'd think it would do the opposite, because it's definitely makes you go a little faster, but it didn't for me. It was just, again, I couldn't describe it at the time, but I just knew that's what I needed, right? That feeling that everything was just what would make me feel okay. It made me feel all right in my own skin, which just led down a really already pretty dark path, right? Of a lot of lying, sneaking out, stealing, getting in trouble. I got in trouble with the law at that age. I got put on probation. My parents tried, some things and tried to ground me, and just was doing what they can because they could see that I was going down this horrible path, but they had no idea how to stop it. Neither did I. All I knew is that I was chasing after that feeling of feeling okay. They decided to send me to my first treatment center when I was 14 in Jamestown, North Dakota. It was actually an adult and an adolescent and an adult treatment center, which was like only broken up with like a divider, which now thinking back probably wasn't the best thing in the world for a child. But I went through that treatment center. I don't really remember a whole lot about it. We went to school out at the state hospital, and I just remember it being kind of fun, right? I kind of put that like on my jacket as like a badge of honor, right? Like I went to treatment. It didn't change anything. Honestly, at that time in my life, I thought people were trying to stop me from being like naughty, right? Like the lying, the stealing, the sneaking out, which was all just a symptom of me trying to get those drugs, right? And so that's what I thought that I was in trouble for, really. So nothing really changed. I don't remember really learning anything there, or nothing hitting home, or it just was a place that I was for a while. And so I came back home, and obviously things didn't change. I didn't change. And so it just got worse. It was just a lot of lying. I was getting arrested a lot more, showing up to school drunk, getting arrested there, getting sent to the Sunrise Youth Barrel, counseling, meeting with my probation officer, more drug tests. But I just did what I could, right? I'd have friends bring clean urine to the courthouse, so I wouldn't fail those tests, and just kept seeking after and doing whatever it took to get the drugs that I needed, right? To get that feeling to feel okay. And at the time, like I didn't know what was happening inside of me. So I couldn't share that with somebody else. I couldn't talk to people and be like, hey, I don't know why, but I need this, right? I didn't know what was happening, but I know now looking back that I was an addict at age of 12, right? It was done and over from that moment on. And I just, like I said, I just kept going down the same stuff, right? Getting in a lot of trouble. My poor parents, they sure tried everything possible, right? Everything possible that they could think of to try to help me. And nothing was working. So I was skirting around probation with the drug testing. And of course, my mom's smarter than she is. I came home one day from school, and she was like, had a drug tested with her. And she's like, we're going to take this. And I can picture being down in her bathroom still to this day, and giving her this drug test, and watching that disappointment and despair and just all this in her eyes when she's watching these lines not show up for cocaine, methamphetamine, opiates, THC, right? There's all these lines are just not coming up. And she's like, oh. I just remember her looking at me, and she's like, just go to your room. She was just so lost. And again, in the same position, did not know how to share with her that I needed those, that I wasn't just trying to be naughty. I wasn't a bad kid. I wasn't purposely just being naughty to be naughty. It was what I had to do to get to the drugs that I needed to feel okay. But I didn't know how to share that with her. And nothing happened that night, but the next day after school, I was in my room looking out my window, and I saw a state vehicle and a police vehicle coming up the road. And sure enough, that was for me. They came in and told me to pack a bag, and that my mom signed over her rights to me, and that I was now a ward of the state, and I was going to a group home. And I can just recall being so angry. I was so angry, but I was not angry that I had to leave my parents. I wasn't angry that I had to leave my siblings. I wasn't angry that I had to leave my school. I was angry that I was going to be pulled away from the drugs that I needed to feel okay. And I was just so upset with her for making this choice to do this to me, right? Because I was just trying to feel okay in my own skin. Like, how did they not know that, right? Like, that's what I kept thinking. Like, why can't they just let me do what I need to do? So I got put into the psych ward in Dickinson for a few days for detox, which was extremely scary for a young kid. And then they sent me to Eckert group home in Williston. I don't know what it was about Eckert, but something there. It was set up. It was a Christian-based group home, and it was set up with like two house parents, two sets of house parents that would stay on a week and a week on. So kind of like there was parents living in the house. There was just a lot of love in that place for a group home, and I did really well there. Actually, I kind of thrived in that environment where there was a lot of structure and a lot of accountability. It seemed like when I was in those positions, I could thrive. And I did well. I went to school my senior year there in Williston, and I did well in the group home, and honestly so well that one of the house parents decided to go forward with getting her foster care license, so that when I was done with the program there that I could, that she could take me in as a foster kid. And they did that. So I completed the program with, high honors. I was loved by everybody there, right? Just not anything that I gave my parents, that's for sure. And so I went into foster care with these house parents, and things were good. I was, still doing okay. Going to school, I met a girl in school, and we became friends pretty quickly. And she smoked weed, and so we would go on our lunch break, and I would smoke with her, and started that process again. And that was the first time I was using since being there. And that just kind of went on for a little while I was there in foster care and in school. I was doing just smoking the weed with her, and it just kind of gradually grew from lunchtime to lunch and after school, and then lunch and after school, and later that night, and then the morning, and it just grew. And I completed that and got turned 18 and was still in the foster home at the time, and trying to work and, smoking weed and kind of maintaining a life of some sort, until I got a call from my childhood best friend. She called and she said that her and a few of our other friends they were going to hit the road and go out of state to go get drugs, and asked if I wanted to go with. And with zero hesitation, no question, I said, yeah, absolutely, I do. And so they came and they picked me up in Williston, and we headed out of state, and we got the drugs that we went to go get. And the whole way home, we hit it really, really hard. And when we got back to North Dakota, we went back to Williston, packed all my stuff, and I moved to Bismarck with them. And that was the beginning to the end, really. My addiction is amazing how it doesn't go backwards in any way. No matter how much time that I had of clean time in between, I started out in the same spot, if not worse, every single time. It never went backwards, that's for sure. And so, and living in Bismarck and on our own, and just, that's kind of when it started, some of the really dark times of my addiction. I got really into meth really hard at that time. Started IV using, because it was much more, it was quicker, and it also made our stuff last longer, right? And so started doing the IV use, and was, I guess, honestly, really just losing my mind. I was really paranoid at the time, chasing my own footsteps, thinking people are following me, seeing things, hearing things, just absolutely losing myself. But every time that I thought that things couldn't get worse, they got worse. Every single time, darker and darker and darker. And so, I met a guy at the time too, right? The boyfriend that I had then, and he was no good either for me. And we just, kind of lived the same life, right? And a lot of using, stealing to maintain, lying, some of the things that I've done in my past, it's almost hard to believe the things that I did back in those days. But, just anything to maintain and to get to keep that drugs, because I needed those to feel okay. We started going down to Denver at that time, back and forth, getting the drugs, because they were a lot cheaper, right? Easier access and a lot cheaper. And so we started doing that, going back and forth and getting, meth and cocaine and marijuana and all the things you could think of, opiates. But one of the times we were down there, the guy that we were meeting with, I said, hey, I got this tar heroin. You guys should definitely take this back. This would get you guys lots of money. And so we did. We did. And so I used heroin for the first time. That was my first time ever doing it. And I used it, IV use. And it was like finding the love of my life. It was like everything that I needed, right? Every single thing. It was just it. That was it. That heroin was just it, right? I never felt the way that I felt. And it was something that made me feel so good and so okay in my own head, right? And I don't know if it was the effect of how if heroin works, and the calmness of it and bringing you down, but it was everything for me at the time. And it got dark. It got dark during that time. I started overdosing quite a bit between me and that boyfriend at the time. We would kind of alternate, right? Throwing each other in the shower, pounding on each other's chests. Narcan was not available back then. So it was a lot of, let's just hope that, throwing them in the cold shower will wake them up, right? So that was happening quite frequently. I also, while using IV use, I blew out so many veins. I started having to find new routes to shoot up, whether it's the feet. I got so desperate one time, well, multiple times, but that I shot up in my neck, right? Anywhere that you could possibly think, I tried at least, which if you know about IV use, you know that can come with a lot of problems. So I had quite a bit of abscesses that I dealt with and different things throughout all of my addiction, really, of IV use, but especially with the heroin. I started getting a lot of abscesses, and I would use, rigs and hot rigs and different things. And eventually they would go away and I would find a new vein and it would heal up on his own. And so I was never really too worried about them, honestly. And I don't know that I was capable of being worried about it, to be honest. But there was one time when I had an abscess on my arm and it was not getting better, no matter how much, I was putting hot rigs on it and, trying to stay away from that vein. It was not getting better. And it started to make my arm swell. And my arm started getting bigger and bigger and bigger. And it was extremely painful. And by the time I decided that I would go to the walk-in clinic, right? Just absolute insanity of this disease, that I was going to take this arm to the walk-in clinic, get some antibiotics, and then leave. It was about 3 times its size of the normal size. And I was just in excruciating pain. So I went into the walk-in clinic, right, looking for my antibiotics. And the nurse looked at me and she was like, "No, you're going to the ER right now. Right now." And I was like, "Oh, all right, okay, I'll go get in my vehicle and I'll drive there." And she was like, "No." No. And where that walk-in clinic was at was literally connected to the hospital. So it was like just a quick little drive. But they made the ambulance come and get me and take me over there. Would not let me go by myself. So they took me into the ER and brought me back and put me in a room. And I can remember just being in so much pain and scared. And the doctor came in, the ER doctor came in, I don't know to this day what his name was, and I sure wish I do, but he came in and he's like, "This is going to be painful, right? This is going to be painful." And they said they had to culture my arm, which was going to hurt. And oh my gosh, did it hurt. It was extremely painful. And because of my IV use and the use of it everywhere, I had no veins that they could get to get an IV in. And so they had to do an IV through my groin into that like main artery, which was another thing that was extremely painful. And so I was hurting so bad and so scared. And to this day, I can remember that ER doctor, he grabbed his little chair, right? And he sat down on it and he put his hand on my arm and he was like, "You are going to kill yourself, right? Like, you are going to die." He's like, "Your life is worth it." I remember him telling me, like, "You have value in this world, right? Like, your life has value, right? Like, it's worth fighting for. But if you don't, you're going to die." And that was the first time I feel like, especially with like medical, in the medical field, that somebody treated me with compassion and love and just like I was a human. I know that when you're dealing with addicts, it can be very challenging. We are very challenging in our addiction, but we're still human, right? We're still somebody's daughter or somebody's son. And our life still has value, just like that doctor said. So it meant a lot to me. And I wish I could say that was it, right? And I got clean and things got better. And it didn't at that time, but it still sticks with me. And it planted a seed in that moment that like maybe there is something better, right? And maybe my life really does have some value. But I wish it was that easy, but I didn't even know how to. I may have wanted to be clean or not live the way I was living, but I did not know how to be clean because I didn't know how to live with myself because I was not okay without the drugs. So of course, I was in the hospital. It ended up being MRSA in my arm too. I got that staph infection. So I was hospitalized for about a month. It was quite some time, but I couldn't not use. And so I was having the boyfriend at the time bring in heroin, and I was shooting up in between my toes. and just doing whatever I could to maintain what I needed to maintain while I was there, right? Just to be okay. It was a dark time, such a dark time. And I think back to these things and I just, again, every time I thought things couldn't get worse, they always did, right? They always got deeper and they always got darker. It just is insanity of this disease. I did get out of the hospital, obviously, and just kept using. I started manufacturing meth in our apartment at the time too, to try to make money, right? To maintain that heroin habit that I had and that I needed. I had to have that, so I needed money to do that. And so we got, of course, in trouble with the law. They raided that apartment, and we weren't actually there at the time, which so we weren't arrested. But I kind of started the life of on the run and using, which was a really challenging time. But my sister, we were in Dickinson at a friend's house while we were on the run, waiting to go to Denver the next day, actually, to go get more heroin. And my sister was begging me to have lunch with her. You know, I never talked to my family at that time. I wasn't able to, right? I couldn't face them. And so she begged me. And I was reluctant, but I was like, okay, fine, I'll go. And bless her heart, she actually had the police and it was a setup. So they had SWAT and everyone there, and they arrested us. So I went to jail in Dickinson for the charges of the stuff I had on me at the time. And then I went to Burley to deal with the charges from the apartment that was raided. But while I was in Burley, the lawyer said that the judge would give me an opportunity to go to treatment. And I wanted out of there because that jail is nasty. So I took that opportunity. I said, yeah, I'll go to treatment. Having been through somewhat treatments, right? The treatment at 14 group home, I was like, oh, I can do that, right? Structured environment, that's no problem. And so I did. I got out and I went to a treatment in Bismarck, and it was good. I really enjoyed it there. It didn't have a lot of rules. It's changed a lot now, but back then it did not have a lot of rules. So it was kind of like this free for all, and I had fun, and I got to drive a car and sit in a hot tub while I was there, and I stayed clean and did stay clean through the time I was there. And when I left, I moved back to Dickinson for the first time, and I moved in with my grandparents, and I lasted about a month outside of treatment because nothing changed, right? Like I didn't work on anything and deal with anything of what was causing me to want to use. And so I couldn't not use because I didn't work through any of that. So it was, right back to the same spot. Again, you don't go backwards at all. You just start right where you were, if not further on. So I was right back to the same cycle of using. And but now I was on probation as well. And so I used that treatment center in Bismarck as my scapegoat, I guess. Anytime my parents got a little bit, suspicious, or anytime probation was questioning, I was like, okay, well, I'll go to treatment, right? I'll go to treatment. I had no problem going there. And so that became like my way out, so I would do well for, a little bit, and I would start using, and then I'd go to treatment, and then I'd get out, and then, back using, go to treatment again. And I did that. And it was a cycle for quite some time. And all of that time just keep, getting darker and deeper every time, right? Nothing changed, nothing got better. I just kept going in my addiction, and just worse and worse. Until one of the last times I went there, because of their laxness at the time, it wasn't a big deal. Like I used a few times throughout the other times I was there or went in and out of there. But this time we were using throughout the whole time. Me and a few other people in the treatment center, we, were shooting up in their bathrooms in between group and drinking at night and just whatever. But I think because there was a few of us, we actually got caught, and they kicked us out. They kicked us out. And I just remember feeling like just so hopeless. And my family was done. They were done with me. They just, I think maybe just a hopeless feeling like we can't help her. The treatment center that I used, and that was my place and my safe place I could go to, I couldn't go back to anymore. Even my foster parents wouldn't help me anymore, which was all of it. I had nobody. I was in absolute despair. And I called Harview in Bismarck, me and the girl that we got kicked out together. And they said, yeah, you can come, right? You can come. So we got ready that night to go to Harview the next day. And I just remember thinking to myself, like, okay, this has to work, right? Like I have to do whatever it takes now whatever it takes to make this, or I need to find a way to die, right? Because I am not going to make it anymore. Like either you get clean, Lucy, or you die. Those are my options walking into Hartview. And so I'm super thankful for that treatment center. It was definitely different than the other treatment center I went through. They took our phones, I couldn't drive. There was a lot of changing and a lot of accountability. But one of the things that they set me up with right away was this program of Suboxone. I got to meet with the doctor. They put me on this medication, right? And I don't know if I spoke on this a little bit, but like going through with opiates, heroin, the withdrawal of that was so frightening that even if there was a want to get clean, the feeling of being afraid to be sick it just overtopped that every time, because it's a feeling like nothing else, right? I mean, I could not make it through withdrawals of that I had to use. And so they told me, here, this medication is going to help with that, right? And not believing that really, because nothing helps with those withdrawals. We took it, right? I took it and I was like, I'll give this a try. And I did work. It worked. I just can't even, still to this day, I just think back that like I had no withdrawals. But not only that, I also wasn't like in my head craving either. Somehow it helped with that as well. And so for the first time, I really got to focus at treatment, I guess, like be present, pay attention in group. I was aware, I was alert. I just was able to really be present in that treatment because of that medication, which is just such a blessing, which really just kind of started this whole culture of recovery for me. I got really involved in NA program and got a sponsor, and I worked the 12 steps, really worked the 12 steps, right? I went through and I did my amends and I did my 4-step, and I worked through all that trauma and the things that caused me, that wanted me to use, why I was the way I was. Somebody told me that this was a disease and it wasn't just my choice. And that was huge too, right? That, hey, like it's not just, something's not just wrong with you. Like you're dealing with the disease of addiction, right? And so that was such a freeing feeling, because so much of my using, that's not the case, right? It's you have a choice. You're choosing to do this. I kept hearing all the time, right? And I just wanted to scream, like, if I could choose, this is not the life that I would have chosen. I didn't grow up, sitting in class asking what I wanted to be. Like, yes, I want to be an addict, right? I want to ruin my life, hurt people I love. That's just not the case. And so it was always so hurtful and just kind of really hard to hear when people would say that, right? You're choosing this. And so to hear somebody say, hey, this is a disease that you're dealing with, right? It was a really freeing thing. So anyways, I worked a program and I got sponsors and I got friends and great support around me, and just really kind of built my life in recovery. I met my now husband, and at about, I think it was about 2 years clean, we had our first child, which was amazing. And recovery has been amazing, truly amazing, but it has not been without its trials either. One of the trials that I struggled with, that was really hard for me, just with the culture of medical that I had, coming in and just being treated so yucky throughout my addiction. When I was pregnant, my doctor took me down on the medication slowly throughout my pregnancy, from 3 into 1. By the time I gave birth, just to, at the time, that's what I think they said needed to happen. I think that's changed now, but I gave birth to my son and he was so perfect and amazing. But the doctors, the nurses, I was treated like I was that person back in the ER room, right? With a MRSA in my arm and an abscess. That's how I was treated that day when I was in there giving birth to my baby. They said that I couldn't breastfeed because of the medication I was on. I had to fight for that right to breastfeed my child. They kept us a lot longer than needed because they were sure that the child was going to go through withdrawals, which he never did. He was perfect, healthy, and amazing. We had no issues whatsoever. But I was just really treated horribly in there. And that was a really big trigger for me at the time. Again, I had a lot of great support, which I'm grateful for. I built a life of recovery. And so people around me, whether it was the doctor at Hartview or nurses or my sponsor or friends or whatever it might have been, I had a lot of support. So that's great. But it was hard. have another child that I obviously gave birth to. That one was here in Dickinson, and the experience was definitely better, but still had a lot of the same, I guess, the same stigma attached to it. And to me, um, they kept us longer, kind of the same story. But the difference in Dickinson was the pediatrician at the time, she was really worried. She held my son longer. I think it was like 3 extra days, even though, again, he was perfect, healthy, no problems. But at his first week appointment, she was like, "What is this medication? Can you tell me about it?" Because she was just in awe that he was healthy and that he was not going through withdrawals and that things were, good. And so she wanted to learn about it, which I thought was really cool. So that was a good experience. But I don't know, recovery's been amazing, right? Like I get to give back now. In my life, I get to help other people, which is so important for me, because if I can help just one person get out of the life of addiction and the despair and everything that comes with it, I just think that would be amazing, just one. But now I get to help multitude of people, and just also do these things like speaking and sharing and just trying to get more knowledge about, the medications that can help and the stigma that comes with it. Just really anything that can help others. If I can do that, then I think I'm doing pretty well. So I really appreciate this opportunity. That's all I got.
Lucy, thank you so much for sharing your story. And especially it's also how you talked about how your kids were treated in the hospital, sort of a nice segue for part of our afternoon and actually the next year of the work that we're going to be doing, because we'll be adding a little bit more of a focus on neonatal for the neonates as well. We do have about 10 minutes or so if anyone has any questions or. Yeah, sure. If you want to.
Yeah, I think we talk on the mic.
Or just right here. We've got
Yeah.
I don't know if the mic's hooked. So if you.
No,
Since
it's
you're
not the
right here,
mic.
you can just ask Lucy.
Hi, Lucy. Thank you so much for sharing. My name is Ramona. Really powerful story. It's hard. Well, I relate because I'm a professional trying to work with mothers, but I'm also raising a 13-year-old and an 11-year-old, and really sensitive to sort of that age that you got pulled in. And I have 2 questions. One is, was there a void there that you think made you more susceptible, or do you think that that's kind of a developmental stage where almost anyone would be really vulnerable to getting pulled into the addiction? And then my other question is kind of, what would you do now for little Lucy? Like if there's a 12-year-old out there, like your parents didn't know what to do, is it hard for you and Matt? Is that what, we just didn't have the right strategies at that time? Are we able to help kids now, or did it take you getting to the point where you felt like you had something to lose, which I think is really hard for a child to even conceive of?
Right. Yeah, those are great questions. So kind of just to answer the first one, or the second one, I'm sorry, as far as like, is there more things to help? Right. I think so. So I have little boys, right? One of them's 9. He's at the age where I started smoking cigarettes, right? I think that maybe there was a little bit of a void in me, a little bit. And then also what comes with the territory of just growing and developing, right, in our brains. I don't know. I know we talk about like hereditary a little bit. My dad was an addict, so I don't know if it was just part of it's in my genes. I don't even know really. But I don't know that I see in my kids how I felt. So I don't know if it was me. I guess I'm not even really sure. But I feel like today, things like that, we are just more open, right? While there's a lot of room to grow, that stigma of addiction has gone down some, right? There's a lot of really innovative things that people are doing, the First Lady with Reinvent Recovery and just different things that are going around, especially in this state where, that it's just like highlighting like, hey, these are not bad people, right? They're dealing with a disease. And so I feel like it's just a lot more talked about than it was when I was that age, right? It wasn't talked about. And one thing, my parents never talked to me about like drugs. They never really talked to me about really much of anything, honestly. They were great parents, honestly. Like, I mean, I grew up in a really good home. I really did, church and on Sundays, Wednesdays, all the time, and, family and dinners. And I mean, it was a really good home, all things considered, but it was very, closed off. Like, it was not very, we couldn't talk openly about things, or at least I didn't feel like we could, about questions or about the world, or, I don't know, just things just weren't talked about. And so for myself now, especially, I talk to my kids. I mean, they're growing up in this in general, I guess, because my work is this, right? I run the sober living home. So they see it, they see the phone call, they hear the phone calls, they're involved with things at the house when we have celebrations. They see people coming and going. And so I explain to them these things, but we also talk about drugs. And one of the things that I heard from Dr. Melissa Hankey one time was, talking about that, these drugs are bad thing, right? And I've done this same speech with them now, is that, hey, we've always heard that, right? Like, don't do drugs, they're bad. But like, why? Right. And when they first try those drugs, they're going to feel amazing. And they're like, well, this isn't so bad. Right. So I've talked to my kids and said, like, hey, drugs feel good, right? They feel good. Right. But there are consequences that happen from when this happens and this, and just more. I want them to be prepared when they enter into that world or those options, and to know the possibilities. And I don't think that was the case at all, especially when I was young. I just think things were just really swept underneath the rug. Mental health was swept underneath the rug. I've had really severe anxiety all my life, for sure, all my life. Um, but that was never dealt with either, right? Like, everything was, I was just pushed off as like I was bad, right? I was naughty, like, it wasn't ever like, hey, like something might be going on, like mental health wise or whatever. And so I just think that if we keep going forward and just really highlighting, mental health disorders, and really just trying to break the stigma of addiction, I think we can do wonders in just those areas. I hope that answered your question.
Yes, thank you.
Thank you, Lucy. Hi, I'm
Yeah.
Liz. I'm a perinatal mental health therapist. I really appreciate you sharing your story. It gives such good background and just a different view. My question is more about, how did those OBGYNs treat you throughout your pregnancy? What questions did they talk to you about? What screening did they do for you, or lack thereof, if there wasn't much? I mean, because you probably were open with some of your background. Right. So I'm just curious about that experience and what was helpful versus hurtful.
Yeah. So with my first son, I got this lady, and like right when I walked in, like the first thing that was talked about was my smoking. Which I know, right? Like, smoking is not good for kids. But it was like the way she presented it, and she was just so critical and just like not helpful, right? Like, it was just a critical thing. It was just, and I was just instantly like, okay, this is not going to work, right? Like, because if this is bad, just wait, right? If my smoking's bad, just wait till you're here. So this is not going to work. It was not a very great experience, but I switched to a male there, and that was great. He was amazing throughout my whole pregnancy. We were just really, it was such an open like dialogue and communication, right? Like, so he knew what medications. I think that medication was still pretty new, that like a lot of it comes from just not understanding, maybe too. Like, I think that there's more of more trainings and understanding now than there was then. But he was just like really willing to like learn and listen, and he knew my struggles, right? Like, and so he would, not that he like okayed things, but it was like, okay, like, you're dealing with this addiction and recovery stuff. Like, if you're, like, he never condemned me, I guess. I struggled with smoking for the huge portion, like, I guess probably halfway through my pregnancy, to be honest, before I could finally get down. And then I got down to like 1 or 2 a day. I mean, I did not do great. And I'm just gonna be honest with you, but I struggled with it. And I was struggling with my like mental health with it. And he just like loved me through that, I guess, and didn't criticize me, and he didn't condemn me for it. He just, encouraged me with like, hey, that's great. You're down some, you're down some. And I just think that like being open, and that communication was just really open with us. Funny story though, when I finally gave birth, he was gone, and the first lady is the one that delivered my son. So that wasn't, and I think maybe that's where maybe if he would have been there, things maybe would have been different as far as the outcome of how I was treated there. But so I guess maybe that's why it was so bad, because they were just, I don't know, they didn't know, but it was pretty awful.
Yeah, Alicia. Yep. Thank you for that answer, Lucy. Got one more question as well.
Okay.
Lucy, thank you so much for your story. I'm Alicia and just really appreciate your courage. I'm looking right at you. I guess everyone's probably not seeing that I'm looking into your eyes right now. So, thank you so much for your courage to share your story, and it's really moving and important for people to hear. My question is relating, you mentioned in the ER that that doctor of all the experiences you had with healthcare professionals, that doctor made the impact. And I hope, I don't know for sure, but I sure hope there were other people who did genuinely care about you during those times, that maybe tried to express genuine, caring for you and things like that, but maybe through until you got to recovery, it may have been hard to see that. And so I'm just wondering for the healthcare professionals that are working with individuals, like, is there certain things that would make it so they realize that genuine caring? Because it sounds like from your story that made a really big impact, but you really only felt it that one time. So would love to know your advice for all of us who work with people every day and want them to know that they're loved and we support them, but we may not be saying the right things or acting the right way.
Yeah. So I think that situation in general was kind of like the perfect storm, right? The situation I was in, the scariness of it, right? He did mention something about like if I went to come in, like the possibility of losing my, I mean, it was just a really intense situation in general. So I think that kind of contributes some, but I know you, like when you said like there might have been other people, but in all reality, there wasn't. I mean, and I can't even put all the blame on there, because we are, like I said, we're difficult to deal with while we're in addiction, right? I did a lot of doctor shopping, right? A lot of trying to get medications, right? I wasn't making the best choices, but like, I guess I'd never had somebody talk to me with such compassion, right? Like in an actual, like, I felt like he was talking to somebody that he cared about, like one of his family members, is how it felt to me. Like it was like a genuine care. And so I don't know, like I said, if maybe it was the intensity of just the whole situation in general, but and like he had such compassion with, like, he got down to my level, right? First of all, he sat on that chair and he wasn't standing over me, and he wasn't, hey, you got to do this. Like he sat next to me and he put his arm on my hand, like it's just, hey, there was such like a depth of like, hey, I really care about you, but you got to change your life. You're going to die. So sometimes it's not about the words as much as like just that action. I don't know. I did not have other experiences like that. I just had a lot of, I guess, a lot of stigma. But I feel like, again, the times now are changing. But I still see that today. So my record, obviously, within the hospital system is still whatever, blacklisted, whatever. It still comes up, right? And so even over my years of recovery, which as recent as only, I think this was only maybe a few years ago, my knee was really hurting. I was having problems with it. I didn't know what was going on. And I went in to the walk-in clinic because I was like, I couldn't even hardly stand on it. And they just brushed me off like so bad, right? Like just instantly. Kind of was like downplaying it, that it wasn't as bad as it was, that I was like making it worse, like they didn't believe me. And I don't remember what started that conversation, but we were talking maybe about like what she could do. And she's like, well, you could wrap it, and I was like, and then she was talking about medications. And I'm like, well, before you go any further, I'm a recovering addict and I can't take any opiates. And when I said that, it was like the whole room shifted. All of a sudden it was like, okay, she's not here for drugs. Now we can treat her like a human, right? Like now it's okay for us to be kind. And she was like, well, let's order this, and we can do that. And we can get an x-ray and we can check that. It was like, all of a sudden now we can treat you like a human being, right? And so it's frustrating, and it happens a lot, and I hear it within the recovery community a lot still today. Like I said, it's gotten better, but I think, I don't know. And I'm not really sure what the answer is, because I know it's a hard spot for you guys. I really do. But I guess just more compassion. And, when they say something, as much as you can without, because it's not like you have to give them medication with, she didn't have to prescribe me opiates. She still could have believed me. Does that make sense?
Well, thank you so much, Lucy, for the last 45 minutes or so. Really appreciated hearing your story and everything. Yeah, I don't know if I can turn around and show that we have, quite a few people in the room as well. I know our Zoom isn't quite how we wanted it set up, but everyone in the room also very much appreciates your story. And so just want to thank you for the time. This is really,
Yeah,
really
thank
great.
you for having me. I appreciate it.
Yes, absolutely. Absolutely.
Okay. Have a good rest of your guys' day. Thanks.
So at this point, we do have lunch scheduled for next hour, correct? Right, 12 to 1 already. So those of us in the room got lunch over here. And then Morgan, should I just leave the Zoom up and we can just log back in at 1? Oh, great.
Yeah. Yeah. And honestly, I think even if we're not going to I mean, she was like, so I think we're gonna have to look at her husband on this one. Do you like the course? So, small town, we only have one single. We can surely get her on the wait list there, but I think we'll probably have to look at I'm thinking, it's not gonna be, I mean, she'll be here through the weekend, and I think she'll next week, but we like to at least, have the conversations with family right away. When we still look, that can take quite a bit of time. So I don't think we need to make any decisions today by any means, but how the weekend goes, we will react, one question I had is, we have to look at nursing home and Valley being the only nurse here. Do you have access to her financing at all? So we do require our financial. Is her daughter power of attorney or does she not have one?
Wendy's. Okay, I need you to go down. You go away.
Right. Okay. Okay, well that, yeah, I'll try that. Okay. I know he got here. Perfect, that sounds good. Yeah. When was that?
The screen share. So now it's a mute.
Mute screen share.
Back to the
No.
slides. Yeah, that's right.
Huh? Well, no, because we need to start the slides. Here, do the slideshow. And then that way.
Perfect. That looks good. And we're unmuted.
But wait, no, I need to get back onto Zoom. Oh, here, we do this. Down. You know, you'd think we would figure Zoom out. Screen share. Screen share this one. Share. But then
I can see the slides.
this one's up for you. Yep, so that's what's being shared. It is
Okay.
unmuted. And we're ready to roll.
Okay, great. Yep. Okay, this afternoon, we're going to talk about a screening format that you can use to talk with people about substance use. And SBIRT has been around for a long time. It stands for Screening, Brief Intervention, and Referral to Treatment. So it gives a very powerful kind of message to people who are just screening for substance use problems, the ability to talk with people about it. And then when you identify risk, that you can refer people to additional services. So part of the magic of this is being able to know what resources you have. I think that's what stops people sometimes from asking the questions is, where do we go from here if somebody does tell us that they have a problem? What do we do? So it's really important that we have good collaboration with, further assessment or opportunities to refer people for services and to know what's available in our community, or even to be able to know what resources to refer people to, via the internet or whatever it might be for more information. But that is an important aspect of SBIRT, which we'll see as we go along here. I just went through all of those. We're still the opioid response network, and we still have all those things. So, and words still matter. So just so you know, just a review of that the words that we use and the way that we use them and how we address this issue is really important, not just for the people in front of us that we're screening, but for us, for each other, to learn to interact well with each other, to communicate with each other about the concerns that we have about the work we're doing and what we're undertaking here in beginning to screen people and ask these questions and to know what to do to help. So in this section, we're going to recognize the need for risky alcohol and substance abuse screening in primary care and identify a screening tool that's been validated for use with adults. We gave you several of them today that Morgan passed out, very different kinds. We're just going to talk a little bit about each one of them, but she had talked with us about each of the facilities that are working are looking to incorporate this into your day-to-day work with your clients. And what tool is going to work best for you is just that, what works best for you. Some of these tools have been around a long time. They have kind of dated language in them, even as I look through these to bring, because I've taught SBIRT a long time, and a long time ago that I actually did an SBIRT training. But the forms that we use, the questions and the way they're asked can be updated too. So that we have some really fine examples to use with pregnant and postpartum women, or women in screening at all. So that's probably your best bet, that one. And but the others are validated and have been used a long time. But it just is a matter of how you're going to implement it and what is going to be most comfortable for you and for your clients and for the flow of your clinic and facility. Who gives the test? Who hands out the questionnaire? Is it something that you do in an interactive kind of ask the questions, or do you hand that person the screening tool and have them fill it out themselves and then bring it into your discussion? One of the things that we have on our table here was developed by one of our great colleagues at the ATTC during their work in a grant that they worked on Don't Quit the Quit that focused on pregnant and postpartum women and who had an opioid use disorder. But one of the things they developed was just this little packet of questions that they left in the room, what do you call it, where everybody gets naked? No, that's not it. Yeah, the exam room. This went completely out of my head. Isn't that weird? Yeah, okay. But I knew what happened there. So you put in the exam room and there are just 3 very simple questions. And then you can hand that to your provider and say, I'd like to discuss these, or the provider might say, I see you marked one of these. Would you like to talk with me about this today? Or those kind. So there are lots of wonderful tools out there and things and expectations that you can have that ease your way into this conversation with your people. But the screening, the brief intervention utilizes a flow algorithm, which I'll talk to you about of how this works. But if you really want to learn how to use SBIRT, there's really great training. There's even a national SBIRT contact where you can have screening and webinar series or, individually paced learning tools, or you can have your whole organization trained in SBIRT together so that you're all kind of talking on the same page, or you can but it is a very well-validated and very user-friendly kind of way to talk to people about substance use problems. So screening is kind of a universal quick assessment that we use to determine the severity of the risk that is being identified or not identified by the people in front of us. And it occurs in a lot of different settings. SBIRT has been used for public health, primary care settings, social services. The grant, the Don't Quit the Quit grant, we did some really wonderful work with WIC organizations in teaching them about SBIRT and about how to utilize this information and to incorporate what they learn into referral and support services for their pregnant and postpartum women. So it works well in a lot of different settings, and a lot of people can learn how to do this and be able to normalize the conversation. So brief intervention is just determining where people at and raise their awareness of the risks of what they're doing, that there are risks that you can identify, that you know something about, even if it's just brief information and education. You can raise their own awareness that what they're doing may cause some consequences to their use. People may have some idea of that, but with the normal use of alcohol, for instance, in our cultures, and the pervasive use of substances, people may not realize the significance of their use or their introduction to substances that can cause ongoing long-term health problems. So it's intended to be really a very short conversation to reinforce abstinence or to stop their substance use or to adapt it in a way that reduces their risk. So then the R and T is referral to treatment services, which is some kind of specialty care. And it can sometimes mean a few sessions with a counselor to just talk about reducing their risk, or sometimes it can mean somebody who's in very risky situations, referring them to more in-depth assessment to an addiction professional. It can be, a lot of different things. It can be an education program that you know about. It can be a seminar coming up that you're aware of. It can be a lot of different things. It can be even pre-recorded messages about substance use that you have available in your clinic situation that you can set somebody up with an iPad and they can watch that and then talk with you about it. So there's a lot of ways to do this that are very user-friendly and very comfortable for the person doing it, non-threatening for somebody who may be threatened by even just talking about this, but also inviting the conversation. And that's really what the whole idea of this is, just being comfortable yourself and inviting people to share and not making this such a mystery any longer. And this serves more than anything else to reduce the stigma around this with healthcare professionals. If you are comfortable in asking the questions, it's a major change. In my own healthcare with my nurse practitioner that I see on a regular basis, every single time I go to the clinic, I get a screening tool that asks me about my substance use, that asks about depression, that asks about anxiety. And, for most of my life, I've had, no issues with any of that. But during the COVID I'm a social person. We did a lot of travel in my work, and all of a sudden here I am at home, working from home with my daughter's dog living with me, so I wouldn't be so lonely. And it was very stressful for me. This was a complete change of life, and I was feeling anxious a lot. And I remember going to see her at one point at that time and saying, I did not know what anxiety felt like until this. I just didn't realize that this kind of isolation would have, she said, you are in a boat with every American person who is, has had this, but it is, what are you doing about it? What can you do to change? How can you, and we had the conversation, and do you think you need medication? I said, I don't think I need medication, but I just need to tell somebody that I'm a changed person. This doesn't feel right. She said that's, there's comfort in saying it out loud and then sharing it with others and realizing that you have the support of those around you. But it was a great opportunity to, I was invited to talk about it with them. So I did. SBIRT promotes behavior change, but it can also reaffirm people's motivations to remain abstinent for a period of time, whether it's during a pregnancy or, for teens before their brains are fully developed. If you can do something to reduce risk to substances by doing the education, and the consequences to the brain and to what happens, it is a remarkable effort on your part with very little time required. So when you do a screen for someone, what really does it tell you? It helps you to identify the kind of drinking that's going on. How harmful is the use of the substance that they're using, and how hazardous or at risk is it? So it's kind of this pyramid of information that you get and what kind of information that you should do. So people who are using rarely or experimental use or whatever, all you have to do is provide some additional information about the risks with use. Harmful use, you do more of an intervention to talk about those risks and make a referral. And then you may, as if people progress into sharing more and more information and that they are at greater risk, you would want to refer them to ongoing services. So most clients that you work with would not self-identify any concerns that they had about their substance use. Most people do not talk about this. It isn't or any risky use that they're involved in unless they're asked to do so. Not something that you walk into, if you're having migraine headaches or if your stomach's upset and you're constipated all the time, you're not going to say, well, gee, I'm taking 15 oxycodone a week that I'm not prescribed, but I'm getting on the street and I don't know why I'm constipated all the time. They're not going to include that information to you, but they're going to talk about the problems that they're having with constipation. That's what they come to see you for. So sometimes you have to uncover the root cause, and lots of us don't think about substance use as the root cause of a lot of the symptoms that people present to us. So due to a variety of factors, providers do not routinely screen for risky alcohol or substance use either, especially in specialty populations like adolescent and obstetric patients. It's more uncommon to see that in a practice that focuses on adolescent or focuses on obstetric care clients. And this is in the information that we get in the surveys that we do and the surveys of providers, and that's where this information comes from. So why don't we ask those questions of people? It's because it is a difficult topic because of the stigma attached to it. Sometimes we have a lack of time and we think if we ask these questions, it's going to lead to all this conversation and it's going to take up all of your clinic time. You're supposed to see 4 patients an hour or whatever it might be, and you've got 15 minutes. And what are you going to spend 5 minutes talking with somebody about their substance use? Or what do you need to, what kind of quality of time can you give to this? Well, that's why it was meant to be really brief assessment tool, brief discussions, unless it leads to something that where somebody is having significant issues, and you can then refer them and understand what you're dealing with in the context of what they came into the clinic to see you for anyway. Sometimes it's just inexperience or just your lack of confidence in asking the questions. And so it takes some practice. It takes some, and that's what the SBIR training really does, is help you practice and to put it into practice and just, you know, to feel more comfortable in doing that. Sometimes it's because you have no resources available for follow-up. What are we going to do? How are we going to help people if we don't have a treatment program open and operating in our community? What if we live in Cucamonga, you know, which is 40 miles to the next, can we do telehealth? Can we offer people that? And we have to look at what resources are available and what we can offer when the issue arises. Sometimes we have a worry about hurting our relationship with the client in front of us. And we think if we ask these hard questions, or if we are nosy about their substance use, that they're not going to want to come back to see us about the real health problems. You know, we have a way sometimes of just talking ourselves out of doing this because we're uncomfortable with it. And sometimes we're convinced because of misinformation that no matter what we do, nothing's going to help, nothing's going to make a difference, and not anything that you can do is going to make a difference if we bring up this topic. But the truth is, and the myth breaker of this one is, if you do bring it up, it opens the conversation to somebody who's been needing to talk about this, wanting to talk about it, and is afraid to. People live with a lot of fear. They do. And they're afraid for what's going on with them physically, or if they're pregnant, they're afraid of the consequences of sharing about this. And even, you know, as Lucy talked about this morning, a person in long-term recovery, the fear that she had about disclosing this and the treatment that she got when she did disclose it, it keeps people from sharing about it. So if you, in your practice, normalize this conversation and make it just a part of your everyday practice, it goes a long way to reducing the stigma. I probably said that 20 times. I'll probably say it 20 more, but it's true. So when you get started with SBIR, you have to have a little information about what it is. So we want to teach you a little bit about standard drinks. What is a standard drink? Because you can ask people, how many drinks do you have? I only have 1 drink a day, but it might be a half a quart of whiskey mixed with a dash of Diet Coke. You don't know, but you know, we're gonna standardize that and talk about the terms that are used, talk about validated screening tools and what appropriate interventions there are, and then the referral sources that you can develop, the collaborative sources. So before you ask the questions, do you know what constitutes a standard drink? So a standard drink is considered, you know, alcohol is alcohol, just to say that, 5 ounces of wine or 12 ounces of beer or 1.5 ounces of hard alcohol. So a mixed drink with 1.5 ounces of alcohol in it. So that's the standards that we use. So when we ask people, how many drinks do you have a day? This is what we want, the information we want to give them. So this is what we consider a drink. Tell us about how this compares to what you drink. So how many shots are in a bottle? This is another graphic that shows how many are there in a miniature bottle, in a quarter pint, a half pint, a pint. A standard bottle or a fifth of alcohol has 16 shots in it. So we want to, you know, give you some context of that. So a liter, a magnum, a half gallon, a double magnum, and I don't know if I can even say Rehoboma. What is that? 101 shots, whatever it is, but I think you'd need a cart to carry it home. So that's 4.5 liters of alcohol. You'd have to have a special shelf for that in a liquor store, wouldn't you? Yeah, I think so. I don't know. So they must exist. There must be manufactured and do that. I haven't spent a lot of time, and every once in a while I have to go into a liquor store just to see what's what. It's horrifying sometimes, the changes that have gone on and how much I've missed, which is not a bad thing, but you know, it is. Beer is one thing that has really changed in the way it's marketed and used. And beer sold in very large volumes, 24-ounce cans, and 40 ounces in a boot. I mean, you can go into a happy hour and get, you know, a pitcher and, you know, to share, and you know, you're not really counting the ounces, but in many cases, the way it's bottled and manufactured and marketed now is quite different as far as the amounts, and way more than what we consider a standard drink with beer. So the terms we use for adult alcohol use and drinking in moderation is females. For females, it's up to 1 drink per day. That is considered moderate drinking. For males, up to 2 drinks a day. These are 2 standard drinks. At-risk drinking moves into drinking more than that recommended daily, weekly, or episodic amount of alcohol. So for females, that's 8 or more drinks per week. For males, it's 15 or more drinks per week. That may sound like a lot to you, but you know, people tend to have an unspoken kind of use of, or not unspoken, but they don't reflect on the amount that they're drinking, and the drinking increases over a period of time, and they're not aware of the amount or how much they're drinking compared to what the standard is, or what the average drink is, or how many constitutes risky drinking. So binge drinking is a pattern of drinking that brings blood alcohol concentrations to levels of 0.08, which is the legal level of intoxication nationwide now. 0.08 constitutes impairment under the influence of alcohol. So for females, that's 4 or more drinks in one setting. And this varies a lot depending on weight, you know, age, health, all that. There's a lot of things that goes. Males, it's 5 drinks and more than 5 drinks, 5 or more drinks in one setting. So that's what constitutes alcohol use. So you have that information at your disposal. Asperg gives you these nice little cards that you can use to explain this, to show it to people, to show what a standard drink is, and then be able to ask the questions and determine how much they're drinking. So there's a couple of pre-screenings that are just a single or 2 question pre-screening tool that the NIAAA, the National Institute of Alcohol Abuse and Alcoholism, I think that's what it stands for. And one of the copies that we gave you was the audit. This is an adult validated tool. The audit asks, I can identify substance use problems. And the DAST, we gave you a copy of that. That's specifically for drug use, questions specific to drug use. And the CUDIT is the CUDIT-R is for marijuana use, specifically for cannabis. So there are lots of different tools. We also gave you a copy of the 5 Ps. So that's probably if you're working with pregnant and postpartum women, the best. So take a really good look at that, because it looks at your family, it looks at your peers, it looks at your past use, your present use, and then moves into your relating your own personal use. But it gives you an opportunity to get background information about that person and the lifestyle they're in and how it works. And it's probably and you know, in learning how to use these tools, there's demonstrations and there's role play demonstrations about how to use them and how to ask the questions, and then how to move from from getting that information and then moving forward with asking people about the outcomes of the screening tool that they filled out for you. So in pre-screening, this is one of the questions commonly asked. Do you sometimes drink beer, wine, or other alcoholic beverages? Simple as that. If they answer yes, then you ask how many times in the past year have you had 5 for men or 4 for women, and all adult males 65 and over or more drinks in one day. So you ask everybody that 4 for women, 5 for men, and for all adults over 65, 4. So that many more in one day. So you add a screening tool then. If you can use this 2 screening test, and and if somebody has not had a problem with substance, move on, and not even produce another screening tool. But anybody who asks that, who responds that, then you can add another tool to that to screen them. So sometimes people feel comfortable just doing that much screening, and are willing to dig deeper if and to go deeper if it's necessary. So the audit that you have is probably the most widely studied tool for detecting alcohol misuse. This has often been used in primary care settings because it's easy to give, easy to interpret, and has a really good sensitivity and specificity across lots of different kinds of populations. So it's 10 questions, self-administered, or you can do an interview with someone and ask the questions yourself, and it takes about 2 to 5 minutes to complete. Bless you. So that you have a copy of that in front of you. So for drug use, you might ask a two-part screening test as well. How many times in the past year have you used an illegal drug or used a prescription medicine for non-medical purposes? Really straightforward question. 0. Screening is complete, but you can educate. You can still say, you can still present information to people. But if it's 1 or more times, then you want to do more risk screening and move into a different kind of tool that will assess for drug use. So the DAST has been around a long time too. This is also a brief self-report instrument that identifies drug problems. It's brief and real inexpensive to administer. Versions have been developed in multiple different languages. It's not that they're being developed, they're available in multiple languages, and easy to obtain on the SAMHSA website. They have we'll give you a list of resources. Abby is our resource queen. She knows everything. So, and where to find it. So we'll give you lots of resources where you can find these things and look for more additional information. Really just this is meant to be kind of an overview of that, what's available out there, what has been used and what is available to you. So this is the DAST, asks the questions, and has a very simple scoring system. So on 0 is no problem, 1 to 2 is monitor, reassess at a later date. You might want to note in the if you're using an electronic system, recording system, that the next time they come in, you want to reassess that, and ask the questions again. It builds a rapport because you've asked the questions, and maybe they'd be more forthcoming with what's going on with them if there's truly substance use that's impacting them. 3 to 5 moderate, and 6 to 8 is substantial and a more intensive assessment required. So real simple scoring system. And then this is the cannabis use disorder identification, developed in the same systems as the audit has been and the DAST has been, validated, can ask questions about cannabis use, and a score of 8 or more on this self-administered survey can indicate hazardous use. 12 or more indicates possible cannabis use disorder, and a referral to further assessment. This is in very small print, but you have a copy of this one, the Institute for Health and Recovery Integrated Screening Tool. This is the one we were talking about, the 5 Ps. and probably the one that's more suited for your use in your situations with working with pregnant and postpartum women. So what is a brief intervention? This is really a short dialogue that you use to focus on prevention or on reducing or stopping substance use. Only takes between 5 and 10 minutes or less. You can probably have someone in your clinic who is well versed in this, who's willing to, if somebody has a positive screening test or you want to give additional information, who can come in with the information, handouts, do the talk, feels very comfortable doing that. But it's really good if all of you can become comfortable in doing this and spend the time, have them right on your desk, hand out, just a brief flyer about substance use and some of the consequences. But the goal really with a brief intervention is just to identify and then intervene at what level you should for moderate or high risk or psychosocial or healthcare problems related to substance use. So you want to really focus in on moderating people's alcohol consumption, eliminating any harmful drinking practices by describing what they would be and what puts them at risk, decreasing or eliminating drug use, and providing education. And then encouraging healthy or smarter choices and just making it that simple. This is what's healthy, this one's, and some people never even hear this kind of information. And you think that, in this day and technical age, people have access to this kind of information, but we don't hear this kind of information, what's risky or what's consequential. It's the more the merrier. If this works, twice as much works better. We're in an age of excess, and you look at the marketing and the advertising for substances, for not even just alcohol, but I love Jeopardy. I've watched Jeopardy my whole life. Just saying this, there's not a single ad during Jeopardy that isn't drug related. All kinds, all the new drugs for this, that, and the other. Now, there's no advertisement for meth, thank goodness, or for other substances of illicit use, but they're all kind of, and I thought, do only older people watch this, or what is this? Nobody watches Jeopardy anymore. But anyway, it's focused on that, and I think about the amount of money that's spent marketing substances, and that we're inundated with it, not just about substances of misuse or abuse, but all kinds of substances. There's always an answer, a medication answer to our issues. So brief intervention is really just education. So the flow in SBIRT, we're kind of good with acronyms, but flow is feedback, listen, and options. So this is a mnemonic that was developed to look at the major elements in a brief intervention. So in giving feedback, first of all, you ask permission. Is it okay if we talk about your answers? Sometimes it's as simple as that. See that you had some positive responses, there's some yeses on your screening. Is it okay if we talk about them? Ask permission to do them. If they're willing, wonderful. If they're not, then you can provide information. Here's some more additional information about this I'll just give you, and we'll move on. Give information. We know that drinking or drug use at your age puts you at risk for whatever that might be. And if you're working with an adolescent, this is a nice way to start the conversation. That your brain isn't developed yet. You have a much more of an impact from substances on your brain at your age than an adult does when you're that's why the drinking age is at 21. And, you can just give, basic kinds of information that way. Or you can elicit a reaction from the person who has given a positive response. You can say, what are your thoughts on that? What do you think about your response? Is this something that concerns you? Are you, that kind of thing, but elicit more information. It's also okay to cuss. This is another acronym, but you can say things like, I'm concerned about the amount of alcohol you described you were using in the past year. It's increased from the last time we talked about this, and you know, this was your answer 6 months ago, we rescreened today, and I'm concerned about the increase, that kind of thing. Or I'm uncomfortable with, you know, it might be the way it's presented or the way somebody sings, or, you know, I'm not interested in talking about that, or you don't really care about that. And you might say, I'm uncomfortable with that kind of response. And I just want to give you some information if you want that, you know, that kind of thing. But if you say how you're feeling in the situation too, sometimes that really helps people level. The S is, I believe, you know, if they're putting someone else at risk, if they're driving under the influence, if there is a safety issue, you could also say too, I believe the stabilization of your diabetes is at risk. Is there's safety in, you know, or if you are drinking alcohol during pregnancy, I'm concerned about your safety and the safety of your unborn child. And here's information about how alcohol impacts, you know, and or drug use, you know, all of those kind of things. But safety might be what gets people's attention, a safety issue. If you drink and drive, that's a safety issue. If it's drink while you're pregnant, that's an issue. Oops. So the listen option, the L and O of the flow, listen is answer the questions that people have. So you ask the questions, do you have questions for me? Be sure you try your best to answer what they might be, and assist that person in the decisions that they make. They make the decisions about what they're willing to do and what they want to do, but you want to assist them in that direction, support whatever decision they make, but assist them in doing that. So options is giving people options and giving them some direction in doing that. What are some steps that will work for you? What do you think would be, what could you do if you want to decrease your drinking? What steps can you take to do that? What do you think you can do to stay healthy and safe? Tell me about a time when you overcame challenges in the past. Try to work with people's strengths and what really works for them, what resiliency they do have, and what their capability is of making some good choices. And what kind of resources did you call upon then? If you met a really good challenge in your life, which of those are available to you now? You know, so you can really look at the support that people have out there. Sometimes they feel very, very much alone in their decisions. All my friends drink, but I don't want to, but I feel like I need to in order to get along with them. I always get teased if I don't. And now there are people that are passing out pills, and it scares me. And so what can you do in situations like that to meet those challenges? If people are disclosing that, it's really good to lead them into what can you do to make a difference here? How can you change that? So there's these wonderful little ruler kinds of things, or readiness assessments that you can say, when somebody's decided that they're going to make a change, well, how confident are you on a scale of 0 to 10 that you can make this change? And they say 2. Well, why wasn't it a 1? What's resilient about you? What's your strength that you think that at 2 you are confident that you can change this? So you work on the strengths. Or how important is this change to you right now is another question you might ask on a scale of 1 to 10. Just real simple questions about how confident they are and how important is this. And if they say 0, why is it 0? Why isn't it even a 1? You know, or if it's 10, why is it so important to you? Tell me why a 10? This is wonderful, but why is it so important? That kind of thing to elicit more information. Referral to treatment is that, you know, for many people think of treatment as residential care, and that's truly not what treatment is. So there is certainly residential assistance for people who need that level of care and intervention. But, you know, with people who are at lower risk or have resources that are not available to them, or do not have a treatment program of that magnitude available to them, then there are interventions that can be using. Outpatient treatment is very effective, and brief treatment is sometimes very effective. Education is very effective. So there's a lot of different things that we can do and resources that we can offer to people that can include chemical use assessment and counseling, determine much more in-depth and look at people's use and how it's impacting their lives, more than just this brief screening. There's a whole continuum of care for substance use, from education all the way to residential treatment, and after residential treatment to recovery housing and supportive sober living, and a lot of other kinds of steps in between. And people can use that continuum as they need to. If they lapse into use and their use escalates and they need more intensive therapy, you can intensify treatment along this continuum and move up and down throughout their lifetime, much like you do with patients with any other chronic illness. Sometimes people are to get them under control, you get, you have start out with large, I think about all the medicines I took right after my heart attack and my stent placement and all this stuff I had to take for that period of time, and how I take an aspirin a day. Things are very different than they were. But you start with that intensity, and certainly we need intensive care. But many times the patients sitting in front of us can be very much impacted by those brief interventions. So for some people, they may need the medications. And I think, I've said this, and anybody will talk about substance use disorders with opioids will talk with you about these medicines and tell you how important they are, to know about them, to utilize them. But I think if anybody was impacted today by anything Lucy said, I hope it's that, how her life is stabilized with the use of that medicine, and how she struggled before that time to reach the level of recovery she's at now. Self-help programs have been around since 1939, the 12 steps and 12-step programs of Alcoholics Anonymous. They have done remarkable work with people with alcohol use disorders, and they're free, they're available everywhere. AA and all of the offshoots of AA, other 12-step programs for cocaine, for cannabis, for eating disorders, but 12-step programs work in amazing ways for people to offer support to each other, and are free and available. And there's programs for teens, there's programs for families in Al-Anon, there's programs for children in Alateen and Alatot. So in some communities they have that too. So it helps families understand the process of substance use and substance disorders. There's lots of times complementary wellness and diet and exercise and meditation programs available. Sometimes a public health department does this. Sometimes it's your insurer will have wellness programs. It's all kinds of things, and encourage people to take part in those, or combinations of any of those things. Those are kind of resources that are available. Referral to treatment are the things that you need to remember and to collaborate with and to know about in your area is what are your resources? Is there a protocol about referral? Does your institution or your program ask you to refer to a certain program in your area that they have maybe a partner relationship with, or they may have developed a collaborative agreement with a treatment program, or they might have a treatment. There's like in Bismarck right now, in the emergency department, if a patient comes in who's overdosed on opioids and is treated with Narcan and stabilized, they can have an appointment that day with an addiction counselor. A warm handoff right over to the treatment program and be seen that day. They've set aside the time to do that in an effort to make sure that people don't fall through the cracks and just get here's where you can go, here's what you can do. But there might be collaborative agreements, in your communities with providers in that way who will make room for a direct referral from you to see that person as soon as possible. And is your infrastructure ready to have referrals? Do you have a list on your electronic record of the things and the resources that are available to you, so you have a quick access and quick information, and a contact person so there can be a warm handoff to somebody that you're referring? And consider having a resource manual handy with all of that available to you. What the insurance information might be and stuff might be something that that program might be able to explain in more detail than you can, but you can say, these people accept Medicare, Medicaid, or these people, you know, just, you know, resources like that, real basic kinds of information. So the algorithm is simple as that, is that those brief screening, the brief intervention, determining the risks of the people in front of you, and then using the flow to give them some feedback, to listen to what their concerns are and their willingness, and then offer the options for them from that. So it's really very simple in that that use of SBIRT. Oh, I don't know why I keep doing this. Sorry. So next steps in your work with SBIRT is, how do you plan to implement it? What do you plan to do in your organization? What kind of screening do you want to do? And what kind of screening instrument would you like to use? There's more even than what we provided for you today. There are more, and we can give you resources to look at what they are and how they're worded, and are they culturally appropriate? Where are they used? Are they used in rural situations? Are they used in urban ones? There's adaptations of all kinds of screening tools that are available to you. So, and who will be doing the screening? You think about your organization and what the flow is in your clinic practice. And do you get your staff buy-in for doing this? Who gives the survey to the patient and explains the importance of their doing it? And where does it go from there? And so that workflow has to be considered too. And how is it coded? Because if you do a screening, your clinic can code and charge for SBIRT. And most insurance companies cover the cost of this screening and the staff time for doing SBIRT. So there is coding, and there's a resource available there to determine that. And the basic resources to talk about are SAMHSA, or the Substance Abuse and Mental Health Services Administration, are always giving availability to the most up-to-date resources and available resources. All of them are free. There's no charge for any of their publications, their trainings, any of that. All of that is through federal funding. So you are in it. So if you want to have handouts for your clinic, they have printed materials available for you that you can utilize, or you can give them access to direct access to SAMHSA. Anybody can utilize SAMHSA, not just providers, but patients looking for information. And then the NIAAA has a youth guide and pocket guide that's available for free download too, for providers to utilize in working with that population. So any questions that any of you have about SBIRT and about those? Yeah. Definitely the process of SBIRT, regardless of what screening tool you're using. But some insurance companies will say, this is what we'd like you to use, or this you will have. They've worked with your organization to develop what tools they want to see utilized, because they should be validated. They shouldn't be something that you've just come up with in your organization. But so that might be a good dig for you to find out if there is some requirements for your organization to use a certain tool. And then, you know, it saves you the time and effort, unless you think it's not worth it, and or there's something better, you can advocate for that then too. So Edinburgh, not, you know, that mental health one. Oh yeah. Are there substance use questions in it? Isn't that amazing? Yeah. You think about it. Yes.
So we can also talk about, if you want to use it to code it, communicable disruption is always a big one, because that's population health. And so thinking about those with HIV, those kinds of diseases, and it can
sexually transmitted infections are on the rise as well. And so we know that that's also a conversation that kind of reducing risk.
Yeah, implement those questions as well, and you've got a wonderful screening opportunity for people who are, you know, at the highest risk there is. Yeah, yeah, yeah.
So it has been around for a
Long time.
And so it's really just it's the process. It's you are screening and you're talking about and you can even use it not only implementing the sleep that you mentioned, mental health. And so they're actually expanding to other kind of screeners and discussions we do have with folks. And so I'm not certain exactly on where it falls within the code, but I'm pretty sure there is an expert building.
If we're just reading, are we going to that, or do I have to do like, she was then screening positive, and then I do an intervention, and then I do the whole process, and then I can do, it's not the presentation that I'm screening that.
But if you are screening and they screen, there's no use, then you've done it. You screen, they aren't using substances, so there was no education. You did the whole process.
You did.
And so in a situation where they screen positive, and then you do have the education, the referral or discussion, then again, it's the whole process which is different.
So in most situations.
Yes.
Absolutely. Yeah, you don't get paid just for the people who need you. You get paid. Yeah, that's right. Yeah. Yeah. They're on it. They're on it. Wonderful, wonderful. It is. Yes.
Yeah. Yeah. And then, you know, that you're not you're not asking them that they are a certain demographic or what have you. But if you say, yeah, everybody.
That's right.
Not you, it's everybody. And so then it also formalizes that conversation and makes them feel a little bit better about just looking up to you to say, I really do struggle with this. And so I'm so happy you're asking.
And there is an opportunity too to say with Esprit that if you're screening everybody, you also get the responses from families who are dealing with this as well and who are saying, you know, this is the first time anybody's ever asked me these questions and I don't have the problem, but I have a son or a daughter or my husband or, you know, and the resources for them are the same as for somebody who gives you a risk and you can refer them. So many, you know, it's just that the conversation never gets asked. It just should be part of, and if you screen everybody, then everybody has a chance to talk about it. And if you think about yourself and the people that you know, how many of us have gone unscathed by the epidemic that we're in right now? I don't know a single person that I talk to who says, I've had no impact from the opioid epidemic in our country, or I don't even know what you're talking about. That's just not the case. It's everybody. And what leveled the playing field for us in substance use was the fact that so many people were introduced to opioids and who probably never would have developed an issue, but were introduced and then cut off and then revert to street use. And that's what's happened. And it's a fact of life with us now. We have to change, and we've done some remarkable things in the right direction, but we have a lot of work to do. So we need everybody's help. So I'm really happy to be able to be here today. And I'm looking forward to having you hear from Kelly now this afternoon. Kelly is our tour representative on our team, ORN team in our region. And she has a remarkable history and impact as well, in working with tribal populations, to just hear her perspective about the cultural aspects of that. And tomorrow morning, our colleague, Heather Momberg, is a nurse practitioner who works, she is the Region 10 coordinator, so out in California and all those beautiful island states. That's what she gets. We get North and South Dakota. No, I'm just kidding. She gets Hawaii, California, Nevada. I don't. So, but she is a remarkable young woman too, and just developed such an interest in working with pregnant and postpartum women with substance use problems, and made that the focus of her practice. And I'm really anxious for you to hear from her too, because she has a lot of expertise in that area. So we're happy to be able to be here. To let you know too that we have a lot of resources available, and want to help you in this effort. So whatever we can do, whatever, we brought a lot of information along with you. Even if you need a thing of Narcan, I brought one and Abby brought one, so you can take them with, because I carry one in my purse all the time. But help yourself if you want a box of Narcan too. So, all right. Any other questions I can answer right now? Yeah, sure. Yes.
So they talked about having resources in the
Mhm.
South Florida has a really good system of care mapped out on the website. DSS website, I think. Yeah, I think it's part of social services, if I remember right. Because they have so it depends on the state, but that's mostly for Medicaid to be for them. And then they have a table, yeah, I think you can look in your community and see what is available for Medicaid users. And then, but I think they also have like peer support resources on there, some virtual, some telehealth options. I can double check and share with you what I think, but that was my remembrance. Yes, so pregnant women typically have, like Martha said, they jump to the top of the list in the priority population. And so if somebody is currently pregnant, they need to jump a wait list. And enter treatment, outpatient care, whatever it is, surgery or wanting to enter, they get better. And so hopefully there would be services available. You know, it's not like a piece. You know, she makes medicine and probably she like treatment. And then we do start and she comes to the hospital and it's withdrawn, she goes through detox, and then again we lose her because she gets discharged and there's no one for her to go. Yeah. And that is a terrible situation, but unfortunately it's the system that we built and that we have to work with, and hopefully that they could integrate her into outpatient or a different level of care, even if it's not residential. Just to get her started, get her connected with a provider who can provide the medication possibly, or a counselor who she can talk to, or peer support. I don't think enough is put onto peer support. I think especially mother to mother, I mean, I don't know, when you're a new mom and you're going through all those feelings, the only person who understands is another new mom who has been there. And so peer support is such a magical thing where you get that instantly. Not only are they going to help you connect to their community within recovery and their AA meetings or their whoever their community, bring people in, and then they're able to see, oh, this is possible. I can raise my children. I can have a happy life and seek recovery with all these supportive people in my life. And so I always think that that's something to think about, because it's super low barrier, because peers they can be friends. They're people in everyday life and they can be from all walks of life. And so it's always nice to think of that right away. Because then, yeah, can I go to a meeting with you? Where do you see somebody? Could you help me make a phone call? Could you give me a ride? All those kinds of things, it's just, it's really a low barrier access in those.
And
Our resources are less.
yes,
So we'll be flexibly able to provide
It's also nice to think about some of the out of the box resources that you have in your communities. Churches are always a nice place where they have folks who are willing to support and give, especially unfortunately when there are children involved. I feel like it goes up a little bit more. But that's also a nice community if that's what folks are seeking. But also to think about, you know, is there an organization, a group of people who get together who would be willing to help or to talk or to start a group or anything like that? I think those are kind of homegrown resources that you can think a little bit out of the box.
Dealing with the fact that, you know, it's Dr. Briggsy is going to be able to compile that list, but how can we maybe support developing that through each facility on what's available, or
it's great.
you know, just trying to community engagement, not just always think about community engagement.
Yes.
But we have and you know, even know all that already, we also identify a whole bunch of phone lines and.
Yes. Yes. Yeah.
Falls, what would you have?
Yeah.
Churches even would be interested in,
Mhm.
so maybe there's ways that we can help. As you can see, or with certain entities that are involved, you can see it from what our office is, community engagement office. Could.
Yeah, well, we've already started it, community reserve, started. And early program for not including the support comments. And something is to make sure that but then it's
Great.
Survey all of the treatment centers and ask them, like, do you take insurance? Do you take it when you family? Do you take what do you offer? And then she compiled it and one icon and to be able to look at and highlight another version of it's not more detailed. And then use that on that. Dual one. And so. So it will be like, we have a right now, yeah. That will then. Send out that the on computer and then. The channels. Right.
yeah. That like so we might have to talk to some of the we're at least future providers and some of what we also believe we're doing was
But he did go through, the, like, national, like, treatment 12 years, but a few years, went through different purges, like, checking it, and then just, and she reached out to get phone call to the first week that right over us, talk about resource. The resource was through communication, so we can go that, you know, we kind of always direct people that we want to try to do things personally, and trust me, getting out of the, they're sugar. And you're not to be updated personally. They have the most up-to-date information. So they are, that's a really good piece. And it's a great situation. Yeah, and next speaker.
Okay, so I know she did a quick introduction of Kelly King, but I want to just read you her bio. She is an Indigenous Resilience Coordinator at Kaufman and Associates, as well as a technology transfer specialist for the Opioid Response Network and responding to tribal opioid response grantees. She is a descendant of the Meskwaki Nation Ponca tribe of Oklahoma and the Sac and Fox tribe of Oklahoma. Kelly received her Bachelor of Science in Sociology from Oklahoma State University before earning her Master's of Social Work degree with a focus in Indigenous trauma and resiliency from the University of Toronto. Kelly has worked in various capacities in the social work field. Some of this experience includes parenting education for parents at risk of losing children to foster care, case management for a mental health facility, serving as a drug and alcohol counselor for youth in a residential treatment facility, case management for a women's reentry program, as well as working as a mental health therapist in a private practice. So Kelly, I will turn it over to you. Thank you for being here. It's great that we get to have this hybrid method and bring in as many voices as we can.
Joining us from Colorado today.
Oh, wow. Okay, so if I
Thank you. Can you hear me?
okay, I'm not sure. Oh, there we go.
Okay. So are you able to hear me?
Yes, we can hear you perfectly.
Okay. Thank you for the introduction. So yeah, today I'm just going to be presenting a presentation on Indigenous consideration and trauma resiliency. And I've put some slides into the presentation that kind of focuses on the work that you all are doing. So I'll go ahead and get started. Let me share my screen here. And then I do have a couple of videos. And when we get to those, you'll have to let me know if the sound is working. So are you able to see my screen?
We sure can.
Yes, we can.
Oh. Perfect. And just a quick question, should I turn my video on so you can see me sharing it, or are you guys okay with me just presenting the Prezi?
You're good to just.
Okay. All right. Well, I will go ahead and get started then. Let me see. hold on, I'm having, okay, here we go. Okay, so you, just to make sure, I have two screens up, so I want to make sure that you guys are seeing my Prezi. Is that correct? Oh. Can you guys see the Prezi?
Yep, we can see it.
Okay, perfect. All right, well, we will get started then. First, I wanted to talk about what, and this is just scratching the surface today, but what tribal life looked like pre-colonization. So we're going to start there. So tribal population pre-colonization, we're going to look at family structure. Many tribes, not all, functioned in a matriarchal way. One example of this was how women created teachings and men articulated them to others. And that was the case for a lot of northern tribes. Some southern tribes are more patriarchal. But this is just, I was just pulling some facts of how life used to be before colonization. Tribal people saw beyond the nuclear family and considered cousins their brothers and sisters, and aunties and uncles as additional mother and father figures. For many tribes, there were rites of passage for children throughout their childhood and into adulthood. Lots of the rites of passages happened during teenage years. Tribal people also place and continue to place a lot of value in non-human things. And some examples of these are the drum beat is the heartbeat, earth is our mother, thunder is our ancestors. So anytime we hear thunderstorms, ever since I was a little girl, and something I've passed on to my son as well, is we're not afraid of thunderstorms, lightning, or anything like that, because that is actually our ancestors. And like I said, many of these still hold true today. So I was raised in a large Native American family on my mom's side, and our cousins were our brothers and sisters. And now that I'm an aunt to my sister's children, I'm an extra mother to them. And we will move into healing practices. So some traditional healing, and obviously this doesn't encompass it all because there are so many, but traditional healing can look like ceremony, medicines from traditional lands specific to tribal location, drumming, sweat lodge, smudging, and smoking off. In the north, they call it smudging. In the south, it's more smoking off. And then many more other traditional healing practices. And since I am presenting to people that work in the field of, in the perinatal field, I wanted to include this. Pregnancy was a time of joy, as it is for most cultures around the world. It was a time of lots of family involvement and support, and a time when rituals and traditions were practiced. Family members might be designated specific roles throughout the pregnancy, during the birth, and beyond. It, of course, was a very spiritual and sacred time. And then childbirth and beyond. In some tribes, women would go to a quiet place and deliver alone. Once the baby was born, the family would continue to fulfill their different roles in the baby's life. Rituals would be performed, and it once again was a sacred time. So in order for us to understand how we've gotten to where we are today, it's important to discuss historical trauma, including colonization, and the impacts that had on Indigenous people. So that will be our next group of slides. So forced relocation of American Indians. 1830, Andrew Jackson signs the Indian Removal Act, saying it would enable states to advance rapidly in population, wealth, and power. 60,000 Indigenous people were forced west to Indian Territory, to land that was unfamiliar and infertile, leaving them with little knowledge on how to survive. It's important to note here that they were experts in farming the land that they lived on, but they were being relocated to places that were unknown to them. Part of this relocation became known as the Trail of Tears, resulting in around 15,000 deaths. The forced relocation would free up 25 million acres of land for white settlement. By 1840, almost all indigenous tribes had been forced west, and the Indian Removal Act, therefore, had achieved its purpose. The bill enabled the federal government to negotiate with northeastern Native American tribes for their ancestral lands in states such as Florida, Georgia, North Carolina, and Tennessee. Some tribes, including the Cherokees, refused to leave their homes and were pushed out by the US military between 1838 and 1839. Thousands of Native Americans died traveling thousands of miles through harsh weather toward unknown territory they were to call home. Enforced assimilation, kill the Indian in him and save the man, is a quote by Richard Henry Pratt, who was the founder of Carlisle Indian School. So forced assimilation began around 1790 when the United States government created policies that gave them control over Native American people, which resulted in loss of language, loss of culture, loss of land, and loss of customs, and loss of so much more. These policies not only caused cultural distress, but were in violation of the US Constitution. The United States government's Native American assimilation policies attempted to Americanize indigenous tribes through control of their schooling, religion, and customs, with a focus on immersion in Euro-American tradition. The nation's first president, George Washington, officially promoted civilization policies. He promoted a system for assimilation, which included impartial justice toward Native Americans, regulation of their land, and promotion of commerce. Sale of native land had to be approved by the United States under the Indian Intercourse Act, and Native Americans were only occupants of the land and not owners. It wouldn't be until 1924 when Native Americans won the right to full US citizenship. However, that didn't guarantee them the right to vote. Many states found ways to deny Native American voting rights until 1975, when the Voting Rights Act was passed. Even then, some states continued to find ways to deny natives the right to vote. Even until recently, there has been fight to make sure that Native Americans have access and the right to vote. And loss of culture. Native Americans were not allowed to practice their religion, were punished for holding ceremony. And this is how powwows were created. Native Americans realized that if they made it a show, that they would be allowed to gather the way that they once did. So powwows were similar, I wouldn't even say similar, but they were a way for Native Americans to be able to gather and wear their regalia and without being punished for it. Most Native children were forced to attend boarding schools or were sent due to those being the only schools in their area. Once their children had their hair cut and were punished for speaking their language. And then we all know abuses of all kinds ran rampant in boarding schools. And we're seeing a lot of what actually happened in boarding schools with the mass graves being found in Canada and some in the US. And the outcome: systemically oppressed people experience substance abuse, obesity, high mortality rates, generational trauma, and that's obviously just to name a few. And then I have a short video giving some Indigenous perspective. And Abby, if you could let me know if the sound is working on this, that would be great. But we'll try to start it.
This land was taken from us. It's like having a wife that was stolen from you. And you see her with somebody else walking. And she looks and she smiles and she still gives you love whenever you're out there. And in your heart, you feel like she's still yours. But she was stolen.
Historical trauma has really bred a ground for disruption completely of a family system, of a parent role, of what safety looks like, even has changed what our social norms are. When termination happened and the lands were liquidated and members were paid out and then no longer considered a federally recognized Native American. So where did we go to lean on services? We went into the community to access healthcare services now, or housing assistance, or whatever it might be. I feel like our people have so many stories of what life was like during that time, the amount of racism that they went up against, the amount of inequity. There was a belief, I think, that ruminated around here that you had everything and look, you just sold it away. And now you want to depend on our resources and our services and bog our systems down. This could have all been avoided. And what most people don't understand is that termination wasn't a choice of the Klamath tribes, that this was a federal policy placed upon them. And so we had a large period of time where our people were hurting, and they were hurting in really harsh ways. In this day and age, we see the fallout of that exact thing. Our adverse childhood experience rates are significantly higher than the state average. We see tribal members come through the doors of our behavioral health clinic. For almost everybody that walks through that door, they have lost a significant amount of family members. They have turned to alcohol and drugs as a way to cope. We do offer both Western and cultural relevant services to them. I think identity is one of the most important areas that we focus on, is getting people to understand that you have a place and a space within this tribe, that there is a responsibility that can give value to your life. Fire, I think, has always been a big part of who we are, whether it was just subsistence and to survive, or that burning spirit that you have inside of yourself, that there's a belief that you always have to be feeding that spirit, just like a fire. You always have to keep it burning. As a behavioral health program, we have to think in those terms, in those traditional ways of thinking. We have to know that a fire exists, that we're responsible for continually kindling it. We don't always want to be seen as the traumatized Indians. We want to be seen as resilient Indians, powerful people connected to our homeland, practicing our traditions and our cultures, separating ourselves apart from just the norm, and being very concrete in who we are as tribal people.
Place matters because it affects us every day. How could you not walk and see your love being controlled by somebody else and it not affect you every day? You restore that relationship and you restore health.
Oops. So now that we've briefly touched on colonization and historical trauma, we're going to move into awareness and the effects that have had on our people. So we're first going to talk about generational trauma. Because of the historical trauma and colonization, our people have experienced unhealthy coping mechanisms that have led to generational trauma. And epigenetics and trauma, this is a quote from New York Times, December 2018, trauma can leave a chemical mark on a person's genes, which then is passed down to subsequent generations. Some stereotypes that are very unhelpful associated with Native Americans are Native Americans are alcoholics, Native Americans get free money, Native Americans are lazy, Native Americans live on reservations, Native Americans are overly sensitive in regard to history, team mascots, etc. Native Americans gamble and like casinos. Native Americans have the same or similar beliefs, customs, and traditions. We'll take a look at some health disparities. So this graph shows how American Indian and Alaska Natives are dying from common diseases at much younger ages than Caucasian people. If you notice the yellow line, which represents American Indian and Alaska Native women, and the dark green line that represent American Indian and Alaska Native men, they both dip significantly, showing that on average, Indigenous people are dying younger from common diseases. Health disparities show the difference in health outcomes for different groups within the population. One such disparity is that on average, American Indians die 12 to 13 years earlier than white Americans. Native people have higher death rates at most ages, but particularly at younger ages, and higher mortality for most of the top leading causes of death. So while it's easy to focus on the numbers, the statistics represent the symptoms of the problem rather than the cause. The specific reasons for health disparities are complex and represent where people live and the services available and accessible to them. Factors such as having a regular source of care, language and communication barriers, lack of diversity in the healthcare workforce, high rates of poverty, lack of insurance coverage, discrimination against American Indians and Alaska Natives, and large distances from healthcare services have all added to the disparities that affect Native communities. And then we'll briefly look at why this could be. The ACE assessment and score, which I'm sure that you guys have all heard of. So it was a study developed by Kaiser Permanente and Centers for Disease Control and Prevention. And they found that there's an association between adverse childhood experiences and health and social problems across the lifespan. It is therefore no surprise that Native people have higher mortality rates when considering ACEs concepts. And when I've worked in behavioral health before, whenever I've done the ACE assessment with someone, I always make sure to follow that up with the resilience assessment, because it's important that people see their strengths. And so this, let's see, the next, oh wait, that's later on in the presentation. We'll cover that in a little bit. So, okay, health and equity. The American Indian and Alaska Native people have long experienced lower health status when compared with other Americans. Lower life expectancy and the disproportionate disease burden exists perhaps because of inadequate education, disproportionate poverty, discrimination in the delivery of health services, and cultural differences. These are broad quality of life issues rooted in economic adversity and poor social conditions. And that was from the Indian Health Service. Now that we've discussed the why, we'll shift our focus on how our Native people are working to move on from the past by focusing on Native resilience. And the first one we'll discuss, and I don't have much time to go too much into historical trauma or any of that. I also don't have time to go into the Indigenous resilience piece. So once again, we're only scratching the surface. So this obviously is not a full list of all of Indigenous resilience. So tribal sovereignty. The Indigenous concepts and practices of self-governance long predated European colonization in the Americas. Sovereignty means many different things to many different tribes. This is because each tribe is unique and autonomous. You could ask 15 different tribes what sovereignty means to them, and you probably get 15 different answers. Because every tribe is so unique. And so long before there was a United States of America, tribes governed themselves, provided for their people, and negotiated treaties with other nations such as England, France, and Spain. When tribes signed treaties with the US, they were guaranteed the right to continue governing themselves. This means that their sovereign rights are retained and not granted. Reclamation. Examples of Indigenous reclamation. There has been land reclamation, protecting treaty rights, and on a much smaller scale, land acknowledgements. Language preservation, ceremony, protecting sacred sites, practicing traditions, customs, cultural practices, and many, many, many more. Finding our way back. Many tribes, if not most, are making efforts to get back to the old traditional way of doing things. This includes bringing in elders to share their wisdom on things such as songs, farming, gardening, sewing, basket weaving, healing practices, and this is also among many other things. I know in my tribe in particular, they have created what they call Red Earth Gardens, and they grow vegetables the traditional way, and then they're able to provide that food to elders, and if there's anything left, they provide it to tribal members. But it's really interesting to learn how they grew things, and it's a beautiful garden, and all of the vegetables are very healthy, and they grow tomatoes from top down instead of growing them kind of from where the plant grows out of the ground. They hang them and they grow down, and it's a really neat thing to see. But I know a lot of tribes are getting back to doing things the traditional way. And so this is what I was talking about earlier about the resilience questionnaire. So resilience factors are born out of ACE concepts and can help people improve their lives. People who have experienced adversity, trauma, and pain tend to also be able to deal with life's twists and turns with more resilience. And so this resilience questionnaire, I'll just warn you, it's long and it's wordy, but I just wanted to put it on here for you guys to have a moment to look at it if you haven't seen it before. Just to see how it can be administered hand in hand with the ACEs assessment. So I'll give you a few seconds to look at this and just kind of get an idea of what it has on here. Okay, so we'll go ahead and move on from this, but it's just good to see it's good for people to recognize that they might have gone through a lot of trauma, but from that they've also gained a lot of resilience. And then here are some programs that are rooted in resilience. So traditional food and nutrition programs like the Red Earth Gardens I was talking about earlier, the Missing and Murdered Indigenous Women Movement, powwows, tribal walks and runs, substance use programs, maternal child wellness programs, exercise programs, boys and girls clubs, and then cultural programs for all age groups, traditional gardening, beading, sewing, drum making, and the list goes on and on. And now we're going to look at the 7th generation. And I'll explain what that is. In Indigenous culture, we're always looking forward to the 7th generation, considering what can we do now that will protect and enhance the lives of our grandchildren's grandchildren. It's important we keep this in mind when thinking about Mother Earth, healing generational trauma, and keeping our culture alive. And now we're going to take a look at perinatal care. The Indigenous consideration. So when working with Native patients, the care may look different than traditional patient care. There may be hesitancy and distrust from the patient. It's important not to interrupt and to be patient. Avoid intrusive questions early in the conversation. Explain what you are writing when documenting. Be honest and clear about your role. And it is acceptable to admit limited knowledge of certain cultures and particular tribes. And then here is a short video about some work that some people are doing in British Columbia, but it can be helpful to see what to consider and how it can look different for Native populations.
We believe that all our children, every human life has a gift to deliver.
So around birth in expectant mothers, our cultures are very diverse. They're very different all across the board.
Cultural practice for the Gitsan is that to have the family members present at the birth, and this is really important because this is where they could take care of the family ceremonies.
It's very important for healthcare practitioners to be able to ask those questions up front, way ahead of time, so that they're aware of who the family expects to be there, for what parts, what function they serve, what role they fulfill. And typically those sorts of conversations aren't had all the way leading up to the time of birth.
So the baby is new to the village, so both the mother side and the paternal side will be gathering in numbers. And there'll be lots of people.
I know with my own daughter, we were told there was too many people.
Going through the birthing process is one where you want your family around for the support, as well as should anything come up during the birthing process, that the family is there should you have an emergency situation where you end up getting medevaced away from the community.
When I had my first child, I had my grandmother, I had my aunts, I had my cousins, I had my mom. I had a lot of women, important women in my life attend the birth, because birth is such a celebration for our people that everybody shows up. And it's kind of difficult because it's limited in a maternity room. When you want to have all these special women in your life be there to celebrate the birth and to be there for support.
When the Wilkes-Selects, also known as the undertakers, works right from birth to death. It's an ongoing thing from what I was taught from my grandmother Lucy. As soon as that baby's born, the so-called Wilkes-Selects clothe the baby, make sure the baby is okay, make sure he's brought up right by his dad. It's a long process, but we are paternally responsible for that child that is born.
Grandparents are very important to have there to witness the birth of the child.
The grandmother comes to visit is in the delivery room also. When the baby is first born, then she will take the baby and examine the baby. This is to look for any recognizable birthmarks on the baby, because in our belief, our family comes back through reincarnation. An aunt of the father is also needs to be in the delivery room, because we have her role to be to cut the umbilical cord, because she is. This signifies that their role as a father clan. It's not the child is no longer just belonging to the mother's family, the maternal family, but the child also belongs to the paternal family.
One of the things when there's a birth, we save the placenta, and traditionally we would take the placenta home and we would tie it in a tree and give back to Mother Earth. I know some of my family members that had taken the placenta home and planted a tree on top of the placenta. So that's important for us to give back to Mother Earth what was given to us through birth.
The father is also given the honor to take that umbilical cord and to bury it in a significant place on their land. It signifies the baby's connection to the land.
It's important to have a phone number, a contact number in case something did go wrong with the baby, instead of just the father and mother being there. They need to know the grandmother's phone number, the baby's grandmother on her mother's side. But it's important to know the paternal side too, because in case something should go wrong with the baby, if the baby dies, it's the paternal side that takes over.
The fetus is taken by a member of the father clan again and buried in a place of significance to the family on their land. Unborn child is isn't lost.
The traditional practices we have was very strict and very sacred.
Well, it's a full circle that they're establishing right from birth to death, and also into the spiritual realm and into the heavenly realm. To honor the cultural practice, you need to ask the family, are you gonna, be following any cultural practice when your child is born? Like I mentioned, the umbilical cord and the washing of the baby. Normally the hospital just does all that. It's good to establish that ahead of time so that there's no confusion when you're in full birth mode. So if you're prepared ahead of time, then well, yes, we need the auntie in there, we need the father in there, and we need the grandmother in there for sure. And some are actually new to it also. Because of the residential school, we didn't get taught with it. If the hospital does not know who to approach in this process, always ask who's the father clan, who's the spokesperson for you.
My son was born. He was 5 weeks early. So we had gone to the hospital in town, and the doctor tried to stop my contractions, saying, you're too early, you're 5 weeks early. Once the IV started, the contractions seemed to get stronger and stronger. So, and I had told the nurse, I said, if you're trying to stop these, it's not stopping, they're getting more and more intense. They sent me to Terrace. So in the meantime, we have family coming, and it was good because, the health staff knew that we were going to be sent to Terrace. I know not a big distance, but, they were still allowing people to come in. Family members that couldn't come to the hospital ended up meeting us in Terrace. And same thing, you have one or two people that won't understand the situation, that you have this huge family that you're going to be bringing a life into this world soon, want to be there. If the individual that's hospitalized is going to be sent off to another hospital, that's their time together, and giving them that time and space to say what they need to before parting. Because if they're sent down to Vancouver, it's not easy being that huge distance away from your family.
Providing a space for the family is also really important, because we have, when a baby is born, you're making that connection for that baby that these are all that baby's relatives. This is all your support system from your maternal side and your paternal side. So you have to have, and people will come in great numbers usually when the baby's born. You have them there to welcome the baby. Just by being present, their spirits are connected right there and then. The father clan also follows the child right from birth to death. Their role is in place right from birth to death. And at every stage of life, there's something that has to be carried out in connection to that child. And birth is where it all starts.
Rites of passage, ceremonies, is that we are very much of a social people, and our clan system, we bring together a lot of people at times of birth and death and dying.
Okay, so more than anything, I hope the video provides understanding and cultural awareness. It's always important to ask the mother or the couple if they will be following any cultural practices and writing those down, making sure that everybody on the team is aware. And then, as you can see by the video, it can vary significantly by tribe, from tribe to tribe. And then how you can help. Things to consider: be aware of your own biases, educate yourself on best practices in working with minority groups, learn ways in which to be culturally intelligent. And we always use the word intelligent rather than competent because we always want to take it a step further than competency, and always be open to learning about different cultures and perspectives. So that is my presentation. I thank you all for having me today. And if there are any questions, I'd be happy to try to answer.
Thank you, Kelly. I don't think there are any questions.
Okay, well.
And there's your beautiful face.
I'm sorry?
Oh, I just said, there's your beautiful face.
Oh gosh. Okay. Well, well, thank you all for, like I said, allowing me to do this today. I'm happy to do it, and hopefully you guys were able to take something away from it. So
Awesome. Thank
Yes,
you.
thank you.
all right, thank you. Bye-bye.
Okay, well,
That's it for Zoom.
that's it. Does anybody have any last thoughts or anything to discuss while we're all still here? It is the afternoon. We are ready for dinner, right? So I will go ahead and wrap up. We'll wrap up a little early today. We do have dinner at the country club. The address is in the agenda that was sent out. If you need it again, we can resend it or just make sure you have it. Stephanie said that they'll put the food out early, about 5:15. They'll try to get the food ready for our group. We have a room, I believe, reserved for us. There is a bar that's cash. We can't pay for your drinks, unfortunately, with our funds, but if we want to head there early and just start decompressing for the day, I guess that would be great. Thank you all for coming and traveling here and spending your day and a half with tomorrow with us. We really appreciate all that you guys do and the work that you're doing to help us be successful as a PQC. A couple of things, we have a couple people spending the night. The hotel information is in the agenda as well. And we'll go do check-ins after dinner. But your name is on your room, so you should be able to check in. There's a card already on there, so you shouldn't have to do any of that. And then tomorrow we'll be back here at 9 a.m. We'll have breakfast again. And we have an awesome interactive training and another presentation for us. We'll be wrapping up by about noon. So thank you guys all for being here. We're gonna, oh, and we have goodie bags. We got a swag stuff this time. So I'm really excited for what we have. So I am gonna let Stephanie hand those out and then make sure you get that. Oh, before we all leave, can I steal pictures by our banner out there and get pictures of everybody? Because we now have social media and I need to be better at posting.